Okay, so first is the fetal erythropoiesis. Okay, in the fetal life, where does erythropoiesis takes place? Okay, in the first 3 to 8 weeks, it was the yolk sac. In the 6 weeks up to the birth, it was the liver. Okay, spleen does also takes part in the erythropoiesis between 10 to 28 weeks. Okay, and the bone marrow, it start taking part in the erythropoiesis at the 18 weeks. Okay, and then in the adults also, the bone marrow is the location where the erythropoiesis takes place. Okay, as you can see in the graph also, this was your yolk sac, and initially the erythropoiesis takes place here. Okay, and after this, in between the 3 to 8 weeks, it was the yolk sac who takes part in the erythropoiesis. Okay, then the liver started, as you can see. Okay, and up to the birth, from fifth week up to the birth, it was the liver who takes part in the erythropoiesis, as you can see, the liver part. Then comes the spleen. As you can see, the spleen takes part in the 10th week and finished at the 28th week. Okay, and then the bone marrow will start taking part at the 18 months and up to the adult life. Okay, it was a bone marrow where the process taking place, right? Then let's talk about the hemoglobin, different type of hemoglobins. In the embryonic life, we have the epsilon hemoglobin. As you can see, this one is the epsilon one. Okay, then the fetal hemoglobin, which is HbF, it consists of two chains, two type of chains, a total of 4 chain, which is the alpha 2 and the gamma 2. Okay, then the adult hemoglobin, which is mostly HbA1. Okay, which is alpha 2 and the beta 2. You also have HbA2, which is alpha 2 and delta 2. Okay, and this HbF, it has a higher affinity for the oxygen. You guys know about the 2,3-BPG, which is 2,3 biphosphorylated. It decreases the affinity of hemoglobin for the oxygen, right? So the fetal hemoglobin, the RBCs, okay, uh, they have a less affinity for the binding to the 2,3-BPG, right? And as a result, they have a higher affinity for the oxygen, because if less hemoglobin binds to the 2,3-BPG, okay, then more hemoglobin can be bind to the oxygen, right? So this fetal hemoglobin has more affinity than the adult hemoglobin, which is HbA1, and that is the reason how the fetus blood can easily extract the oxygen from the mother's blood. Okay, very important. So as you can see, the epsilon chains, they're at the birth initially in the embryonic life. Okay, and then the alpha chain start synthesizing first in the yolk sac and then in the spleen, uh, in the liver and then in the spleen. This is the alpha chain, as you can see. This is the gamma chain, which is a dominant chain at the time of embryonic life. Okay, at the time of birth, it will start decreasing. Okay, and after around 6 weeks or 12 weeks, the levels will be very much decreased. And then comes the beta hemoglobin, which at 6 weeks after the birth, it will take over the gamma chain, right? And now it becomes the predominant chain in the hemoglobin, the alpha 1 and the beta 1. Okay, alpha 2, beta 2, sorry. Yes. So that was about the hemoglobin development. Okay, initially at the time of embryonic life, it was the alpha 2 and the gamma 2. Okay, soon after the birth, the gamma 2, it will start decreasing. Okay, and the beta chain level will start rising. Okay, and after the 6 weeks, this chain, the beta chain, it will be the predominant chain, and the gamma chain will be very much reduced. Okay, so any symptom which happens because of any beta chain mutation, okay, for example, the sickle cell anemia or the beta thalassemia, right? Their symptoms will only, will only arise after the 6 weeks. Before 6 weeks, the baby has no symptoms. Okay, only after 6 weeks, the symptom will be started happening, right? When this chain level will be decreased very much. Okay, it's important. Oh, it is months, not a week. Sorry, it is months. Okay, so only after 6 months you will have the symptoms for the beta thalassemia or the sickle cell anemia. But if any kind of mutation or defect happen in the alpha chain, because this chain is present also in the fetal life, right? So symptoms will be occurring in the fetal life also. Okay, and it's mostly the fetal hydrops which you will see if any kind of alpha chain defect happens. Is that okay?
Yeah.
Yes.
So make sure if you have any alpha mutation, in that case, it will be present at the time of birth and before the birth also in the embryonic life. Any beta chain defect will be only present after 6 months. Then comes a familial erythrocytosis case in which you have a mutation in the beta globin chain. Okay, so that the binding of the beta globin chain to the 2,3-BPG is decreased. Now, if the binding of this beta globin chain for the 2,3-BPG is decreased, then as a result, the affinity of the beta globin chain for the oxygen is now increased. As a result, this adult hemoglobin will release less oxygen in the tissues. As a result, the tissue hypoxia will happen. When the tissue hypoxia happens, the erythropoietin will be released by the kidneys, right? And that leads to the erythrocytosis. As a result, these patients, okay, who have this kind of mutation, they will have a higher level of hemoglobin, a higher level of RBCs, okay, like 7 or 8 millions, okay, instead of 5 million. Is that okay? So Stefan can ask you, what this hemoglobin will be similar to, right? This adult hemoglobin, so it will be similar to the fetal hemoglobin because fetal hemoglobin also has the higher affinity for the oxygen, right? Because of less binding to the 2,3-BPG. Okay.
Yeah.
This is a case of familial erythrocytosis. Do you remember this case? Then the blood groups, you have A, B, AB, and O blood group depending on the antigen on the RBCs present, right? So these are the major antigens, the ABO antigen, okay? Other antigen is smaller one, includes the RH and many other modes, okay? But we need to study just the RH antigen here, right? So for the RBCs who have A antigen, we call them the blood group A type. For the RBCs who have the B antigen, we call them blood group B type. Okay, for the RBCs who have both A and B, we call them AB type. And those RBCs who do not have any antigen, we call them O type, right? By default, okay, this A type of RBCs in the blood, you have the anti-B antibodies, which are IgM type, okay? And does it present at the time of birth or after the birth? I mean, these antibodies, the anti-B antibodies, does it present since the birth or just after the birth?
After birth, after the person acquires any kind of
Yeah,
antigen.
exactly. And it happens like, there's no specific cause to it. Okay. It can happen at any time in the life, right? Somehow you always acquire the antibodies, right? So for the blood group A, you will have the anti-B antibodies. For the blood group B, you have the anti-A antibodies. For the AB, because both antigens are present, so no antibody will form against them, so no antibodies. For the O, because they do not have any antigens, so they will have both anti-A and anti-B antibodies. And please note that these are IgG types also. So both IgM antibodies and IgG antibodies are present. So if a baby whose blood group is A or B is born to a O mother, okay, then they can still have this hemolysis, right, in the birth, so in the fetal life, right, because of this presence of IgG antibodies, and they can easily cross the placenta. Okay, for the RS classification, you either have the RH you you either has a RH antigen or you do not have as a this antigen, right? So if you have the RH antigen, you call it RH positive. If you do not have the antigen, you call it RH negative. For the RH positive RBCs, you do not have any antibody in the plasma. Okay, for the RH negative RBCs, you have the anti-D antibodies. Very important, you call it them anti-D antibodies, and these are also IgG type, which means they can easily cross the placenta and can cause the hemolysis in the fetus, right? So a patient with blood group A, they can, they can only receive the blood group A or the blood group O, okay? And if they receive any blood group B or AB, then the hemolysis will occur, right? In case of B, if they receive A or AB, then the hemolysis will occur. They can receive the blood group B or this O blood group. For the AB, because they do not have any antibody, they can receive any of the blood group A, B, O, anyone, and that's why we call them the universal recipient of the RBCs. Okay, and because they do not have any antibodies, so they can donate their plasma to anyone, to O, to B, and to A, and that's why you call them the universal donor of the plasma. So they are universal recipient of the RBCs and a universal donor of the plasma. For the blood group O, they can donate their RBCs to anyone. Okay, so you call them the universal RBC donor. Okay, very important. And because they do not have any antibodies on the O blood group on this on these RBCs, that means they can receive any of the plasma, anti-A, anti-B, or none. So you call them the universal recipient of the plasma. So for the AB, they are the universal recipient of RBCs and universal donor of the plasma. For O, they are universal donor of the RBCs and a universal recipient of the plasma. Okay. Now comes the hemolytic disease of newborn, also known as erythroblastosis fetalis. Okay, these are two types, either the Rh hemolytic or the ABO hemolytic. In case of Rh hemolytic, the mother will be Rh negative and the fetus will be Rh positive. So because this Rh negative mother, it will have the antibodies against the Rh positive RBCs, the anti-D antibodies, and these are IgG types, right? So they can easily cross the placenta and can cause the hemolysis in the fetal life, right? So initially, when the first baby happens, okay, everything will be absolutely normal because the mother blood still do not have any antibodies against the Rh antigen. Okay, only after the first birth, when the some amount of blood will be mixed with the fetus blood, okay, then the formation of these antibodies takes place. And in the second pregnancy, right, when the fetus is again Rh positive and the mother is Rh negative, then these antibodies, because they're already present in the plasma, they can easily cross the placenta and can cause the hemolysis in the fetus, right? And when the hemolysis happens, your RBCs are being destroyed. You cannot carry the oxygen. If you cannot carry the oxygen, what's gonna happen? Hypoxia will happen, right? Compensatory mechanisms will take place, and your heart will start pumping more blood so that more oxygen could be delivered to the tissues. In doing so, the heart will ultimately get exhausted, and when the heart get exhausted, what's gonna happen? Edema throughout the body, right? You will have ascites, the pulmonary edema, right? Your kidneys will fail, the liver will fail, and hepatic congestion will occur, splenic congestion will occur, and that thing, everything is known as the fetal hydrops. Okay, yeah, hydrops fetalis. Yes.
Yeah.
Sorry, can you explain what's happening to the heart?
See, whenever the oxygen levels are dropping because the RBCs are being destroyed, your heart will try to compensate it by increasing the cardiac output, right? So it would be a high output cardiac failure in the patient, in the baby.
Okay,
Okay.
that makes sense. Thank you.
So because of high output cardiac failure, everything gonna, uh, this fetus will have the ascites, the pulmonary edema, the hepatic congestion, the splenic congestion, and the organ failures, right? And ultimately, he will have the hydrops fetalis. Okay. Because of the hemolysis, they will also have the jaundice shortly after the birth. Okay. And because after the hemolysis, the unconjugated bilirubins will rise. That can even lead to the kernicterus. Yes. So this is what happening in the this Rh hemolytic disease or the erythroblastosis fetalis. So how you can prevent it? Shortly after the birth, okay, even during the third trimester of the pregnancy, of the first pregnancy, you need to give the small amount of IgG antibodies, a very small amount, which just cause a mild hemolysis, not the major one. Okay, and during the delivery of the fetus, because the blood is now mixing with the mother's blood, okay, before the antibodies form, okay, and, uh, and because and before these, uh, what I can say, before these cells will sensitize with this Rh antigen. Okay, you need to give the patient anti-D antibodies. Okay, because if you give the anti-D antibodies at the very initial time of the mixing, okay, then this anti-D antibodies will destroy the RBCs of the fetus, right? And as a result, the sensitization with the antigen will not take place in the mother's blood, and as a result, she won't develop the anti-D antibodies, right? And the second pregnancy will be normal. So the treatment will be to administer the anti-D IgG antibodies, okay, during the third trimester and in the early postpartum period, so that these anti-D antibodies they will destroy the Rh positive these RBCs in the mother's blood, and as a result, the mother's blood won't form the antibodies against this Rh antigen. Okay, this is a treatment. Any doubt in it?
Could you please explain how the fetus's blood gets entry into the mother's circulation?
At the time of placenta delivery, see, the placenta is full of blood,
Yeah.
right? So at the time of delivery, some amount of blood get mixed with this mother's blood. Okay, it happens always. Some amount, very little amount. Okay, and this amount is enough to cause the formation of these antibodies, right?
Okay, got it. Thank you.
Okay, so in case if you suspect any case of erythroblastosis fetalis, okay, So before the pregnancy, what you can do, you can check the mother and the father for the Rh antigens, and you guys must know that Rh positive, it is a kind of dominant type of antigen. So whenever it is present, the blood will always be Rh positive. Okay, this Rh antigen is a dominant type, right? Whenever it is present, the blood will be Rh positive. Okay, so you need to check both the father and the mother for this Rh antigen present or not, right? If you fail to do so, then in case of the birth at the time of pregnancy, you can do the amniocentesis, okay, in which you check the amniotic fluid for the bilirubin levels, because you know if the mother is Rh negative and the father is Rh positive, then hemolysis must be occurring at the time of second birth, right? So you can check the bilirubin level in the amniotic fluid, okay, in case of a suspected this case. This is gracilis fetalis. Okay, so we'll check the bilirubin level for that. Is that okay?
I have one question.
Yes.
Yeah, the level of bilirubin is checked during the second pregnancy, right?
Yes.
Okay. Thank you.
First will be, because first will be absolutely normal. Nothing gonna happen in the first time, right?
Yeah, right.
This case is only for the second pregnancy.
Okay, yeah. Thank you.
Now comes the ABO hemolytic disease of the newborn, in which the mother will be O type, okay, and the baby could be A type or B type, okay. Now, what's gonna happen, because this O type mother, it already has a preformed antibodies against the A and the B blood group, right? So this case won't happen in the second pregnancy. Well, it will happen in second pregnancy, but it will also present itself in the first pregnancy also, right? Because these antibodies are already existing. Okay, so these antibodies, because you guys know these are of IgG types, right? So these IgG antibodies, they will easily cross the placenta and enters the fetus blood, and also in the first pregnancy, it will cause the hemolysis there, right? So the so this fetus will have a high level of hemoglobin. The bilirubin, right? Okay, and they will have a mild hemolysis. Okay, unlike the Rh disease, okay, this hemolysis won't be much severe type. Okay, it won't be very severe type. It will be very less severe. Okay, and the jaundice will happen within the first 24 hours of the birth. Okay, very important. So what you can do the phototherapy, because as soon as the delivery occurred, the antibodies level will start falling, right? So you just need to give the patient phototherapy, right? Or you can do the exchange transfusion, in which you will remove these IgG antibodies type, okay, from the blood. Okay, so yeah, that would be all about it.
Can you explain why the blood type O is considered as having the universal recipients of plasma?
See, it is universal recipient because you know that RBCs, it do not have any antigen. So if you give the A blood, which has anti-B antibodies, and the B blood group, which has anti-A antibodies, or the this AB group, which do not have any kind of antibodies. If you give this plasma to this patient, because they already have the anti-A and anti-B antibodies, so nothing gonna happen, right? Because his RBCs, they do not have any antigen on them, right? In the plasma, you have these antibodies, right?
Yeah, but why can't AB can be a universal recipient of plasma?
It has the antigen, the AB antigen. If you give the A antibodies, well, they will attack the RBCs, and if you give the B antibodies, they will attack the RBCs. Hemolysis will occur, right?
Right. Yeah,
So they
yeah.
cannot
Okay.
receive the plasma, but they can receive the RBCs, right? Because these RBCs, they have the A antigen and the B antigen, which are already present on the AB these type of RBCs, right? And because they do not have any antibodies, so no antibody will be there to attack the A or the B blood group, right? So they
Right.
can
Got it.
donate their plasma and they can receive the RBCs. And these
Yeah.
O type of and these O types, they can give their RBCs and can receive the plasma.
Okay. Thank you.
And this is a type 2 hypersensitivity reaction. I hope you all know about that already, right? And what you can do is a direct POOM test you will do, okay, in which you will detect the IgG antibodies against this fetus Rh antigen, right? So it will be a positive direct POOM test in both these cases. Any doubts so far?
No, thank you.
I actually had one question. So when we're talking about the antibodies in the plasma, So the
Yes.
anti-B, anti-A are both IgM, but on the O, it says it can be IgM and IgG.
It
Is
has
that
both it has both IgM and IgG, and this IgG will cross the placenta.
okay?
Yes.
So the other
And
ones will not cross the placenta.
no. IgM cannot cross the placenta, right? It have a very big size.
Yeah.
Remember the pentameric form of IgM antibodies?
Okay.
They cannot
That's
cross the placenta.
all right. Thank you.
Okay, the embryology is done, and now let's study the anatomy. Okay, first we need to know how these blood cells form in the bone marrow. Okay, so first you will have a multipotent stem cells. Okay, they can go in two ways. Either they become the myeloid stem cells or they can become the lymphoid stem cells. Okay, the myeloid stem cells, they will then further form the erythrocytes and the platelets, the eosinophils, the basophils, neutrophils, macrophages, and other cells, right? And these lymphoid stem cells, they will form the NK cells and the lymphocytes. Okay, so these myeloid stem cells can go under the erythropoiesis, they will become the erythroblast. Okay, and blast cells are the immature cells, which will form the reticulocytes. Okay, and these reticulocytes, they can enter the blood. Okay, and they will form the erythrocytes in the blood. Okay, these reticulocytes, they will enter the blood and they will become then the erythrocytes. These myeloid stem cells, they can also undergo thrombopoiesis, in which they become the megakaryoblast. And this megakaryoblast will give rise to megakaryocyte. See, the blast form is the immature form, and this cyte form is the mature form. Okay. And these megakaryocytes will enter the bloodstream, they will go to the lungs, and in the lungs, they will form the platelets there. Okay. Now, these myeloid stem cells, they can also undergo the granulocytopoiesis, okay, in which they can either become the eosinophils or the basophils, or they become the band cells, okay, and from the band cells they will become the neutrophils. Okay, so all these cells, the neutrophils, basophils, and the eosinophils, they are all formed from same cells, which are the myeloblast cells. Okay, and yeah, that would be it. Then they can also undergo the monocytopoiesis, okay, and in which they will become and they will become the first the monoblast cells. Okay, these monoblast cells, they will form the monocytes. Okay, and these monocytes will be circulating in the blood. Okay, whenever the monocytes go to the tissues, you will call them the macrophages. So these macrophages are nothing but the tissue monocytes. Okay, and for the lymphoid stem cells, you will have the lymphoblast cells. These these cells, what they can form either the B cell, either the T cells, or the NK cells. And please note that these lymphocytes, they are the part of which type of immune system?
Cell-mediated immunity.
Yeah, acquired or that type?
Acquired.
Acquired type, right? And these NK cells,
Innate.
yeah, innate immunity. Okay, please remember that. Okay, very important. So yeah, that would be it. And what interleukin form the eosinophils? These are the interleukin 5. Okay, do remember this fact also. And yeah, after this myeloblast, okay, this myeloblast will undergo to form the promyelocyte. Okay, then it will form the myelocyte. Okay, and then it will form the metamyelocyte, which is a maturation stage, right? And after that, this myelocyte, the metamyelocyte, it will become the band cells. Okay, and then it will become the neutrophils. Okay, but you don't need to know the every step. You just know that myeloblast, they can form the directly band cells. Okay, by the process, of course, the promyelocyte, myelocyte, metamyelocyte, and then they will form the neutrophils. Okay, very important. Yeah, that would be all about it. Any doubt in that flowchart?
I have one question.
Yes.
Could you please explain what you said about the lungs and megakaryocytes?
We have discussed that already many times, I think. In case of this disease, we call it osteoarthropathy, in which
Okay.
the clubbing,
Yeah.
remember?
Clubbing. Yeah, I got it.
Yes. So this
Okay.
megakaryocyte, they will enter the lungs, and if any kind of vascular deformation occur, then they can bypass the lungs and can enter the fingertips, right? And where they can cause a clubbing.
Right. Yeah. Okay.
So these megakaryocytes, they will release the platelets only in the lungs.
Okay. Got it. Thank you.
I have a question. Where
Yes.
does mast cell come from? Mast cells.
The mast cells are from the use of these cells, the basophil cells, but they will form the mast cells, right, in the tissues.
Okay, in the tissues.
Yeah, you call them the basophil cells in the blood, and when they enter tissues, you call them the mast cells.
Okay, thank you.
Okay, now let's discuss about the neutrophils. Okay, neutrophils, you guys already know these are the hallmark feature of any acute inflammation, right? Whenever the acute inflammation takes place, you will always find the neutrophils there, right? And they increase in the bacterial infections. Very important, right? They have this phagocytic type of function. Okay, they will phagocytose a bacteria or any kind of other pathogens. And after phagocytosing, these bacteria can go two process. One is the lysosomal destruction, and second is the respiratory burst. Okay, and they have the multilobulated nucleus. As you can see, these are the lobes of the nucleus. See, this is multilobulated, not the multinuclear. Okay, they have multiple lobules of same nucleus. Okay, and they also have the leukocyte alkaline phosphate. Okay, which will make the environment kind of basic. Okay, they have collagenases, they have lysosomal enzymes, they have the lactoferrin. Okay, which will kind of bind to the iron and sequester it, so that these microbes cannot feed on our iron stores, right? They also have the OR rods, okay, which are the lysosomes. Okay, and they also have the proteinases, myeloperoxidases, and the beta glucuronidases. Okay, you don't need to remember every enzyme, just know 2 3 which are important ones. One is a leukocyte alkaline phosphate. Okay, the second important one is the OR rods. Okay, third is the myeloperoxidase, and fourth is the beta glucuronidase. Okay, remember this beta glucuronidase enzyme? We have discussed it previously.
Gaucher disease.
Yes. Now, and recently,
For
Uterine
conjugation.
deconjugation by
or
bacteria.
Conjugation.
Deconjugation.
deconjugation, not the conjugation.
Yeah.
It was the deconjugation, right?
Okay. Yeah.
Do remember that? Okay. Yes. And okay, so remember this beta glucuronidase for the Gaucher's disease and for the deconjugation. Okay, two areas. Okay, and whenever you have the hypersegmented neutrophils, in which, as you can see, these neutrophils, they generally have 4 lobes, 3 to 5 lobes. Okay, generally, as you can see, 1 2 3 and 4. This neutrophil has 4 lobes. Okay, if the neutrophils has more than 6 lobes, okay, you call them the hypersegmented neutrophils. And the hypersegmented neutrophils are the hallmark feature of the vitamin B12 and the folate deficiency. See what happens at the time of formation of these neutrophils when they are immature. Okay, so they will have the very uh, at the time of immaturity, they will have the more number of lobes, right? And as the neutrophils matures, their number of lobes will start decreasing. Okay, but because you know that for the maturation they requires these nucleotides, right? And these nucleotides will be formed by the vitamin B9 and the vitamin B12. So if you have a deficiency of vitamin B9 or the vitamin B12, then the maturation of these neutrophils will not happen. As a result, these neutrophils will be remaining immature. Okay, and when they are immature, they will have more number of lobes in the nucleus. So you will have more than 6 lobes, the hypersegmented neutrophils. Okay, now whenever you have any acute infection, okay, then these neutrophils will be released in the blood at a very early stage. Okay, and as a result, sometimes the band cells will also seen in the blood in the PBS. Okay, and these are the immature neutrophils. Okay, so whenever you have the infection, you can also have the band cells in the blood because of immature release of the neutrophils. Okay, you will call them the left shift. Okay, you will call it the left shift. Okay, in case of CML, you can even have the this promyelocyte form. Okay, in case of CML, you can also have the promyelocyte form in the blood, which is kind of more immature stage, right? In case of any infection, you can have the band cells up to, I think, okay, or this myelocyte form also, right? So up to the myelocyte, you will call that the bacterial infection could be there. If the CML is there, okay, in that case, you can even have the promyelocytes in the blood. Okay, very important to note. So whenever you have any kind of infection or any kind of leukemia, you will have the immature neutrophils, right? And by looking at the stages of the neutrophils, you can determine whether the patient is having a bacterial infection or this leukemia. Okay, yeah.
Yes.
Okay, now the chemotactic agents for the neutrophils. We already know about that, the C5a, interleukin 8, and leukotriene B4. These are the most important ones. Okay, least important ones are the kallikrein and the platelet activating factor, right? These tools are also very important. You also have the integrins. Remember the function of integrins? It will bind to what receptors?
PE cam.
Not the PE cam, not the P cam. No. PCAM for PCAM. PCAM 1, PCAM 2. They interact with each other, not with the integrins. ICAM, right? Yes,
Yeah, yeah, yeah.
ICAM. Don't forget that integrins will interact with the ICAM molecules, right? And you also call them the LFA1 or sometimes the this MAC1 name, right? So CD18s, the integrins, and this LFA1 or the MAC1, they are all same things. Okay. Then this left shift is also known as a leukemoid reaction, in which you have the many immature neutrophils in the blood because of any kind of infection. Along with that, you will also have the leukocytosis, which makes sense. Whenever you have the infection, you will have a high number of these neutrophils. Okay. Early these band forms and the early neutrophils precursors like the myelocytes, okay, they can also be released in the blood. Versus in case of CML, you will have the more immature forms, okay, like the promyelocyte and even sometimes the myeloblast. Okay, what will you see in the peripheral blood smear? First thing is, of course, the neutrophils, the band forms, and, and many other immature cells, right? Second is the dole bodies in the neutrophils. Okay, these dole bodies are kind of a basophilic bodies, which you will see in the neutrophil, okay, which are kind of bluish in color, and it is because of the presence of ribosomes. Okay, this RNA in the ribosomes, right? It will gives the this dole bodies a blue color. Okay. Other findings, they will have the toxic granules, right? Because you know that these these neutrophils, they are filled of, they're full of granules, right? And these granules contain the LF and this LAP, the collagenases or rods and other things also, right? So you will have, the toxic granules in them. You will have the cytoplasmic vacuole. Sometimes they will show you a picture of PBS and which the neutrophils will be having some kind of vacuoles, the empty spaces. Okay. So don't get confused. It is just because of the disinfection thing, right? And it will have an increased bands. Okay, you will have the increased band forms. You will have the cytoplasmic vacuoles. You will have the toxic granules, and you will have the dole bodies. And let me show you the dole bodies so you can have a better understanding. Just give me a second. See, these are the dole bodies, the basophilic bodies. Okay, these bodies, as you can see, These are the Dole bodies, okay? The basophilic ones. And they will ask you why these are basophilic because of the presence of this RNA in the ribosomes. Okay, it will give them the basophilic color, okay? And as you can see also, these are toxic granules in the in this neutrophils, okay? And these are all the signs of any acute disinfection in the body, okay? And these pictures can also show you the vacuoles. Um, no vacuoles. Anyway, so is that okay? You will have the Dole bodies, you will have the toxic granules, you will have the cytoplasmic vacuoles, and you will have more band forms in the PPS. These are all the signs of leukemoid reaction. Are we good?
Yeah.
And you also need to check for the alkaline phosphatase level, right? If the alkaline phosphatase levels are rising, that means the neutrophils which you are seeing in the PBS are the functional neutrophils. They are functioning, right? If the alkaline phosphate levels are normal or low, that means the neutrophils which are seeing in the PBS, they are not functioning, okay? And when they are not functioning and they're dividing, that means it is a cancer, it is a leukemia, okay? These are the signs. Any doubt on this page?
No, thank you.
Then comes the erythrocytes. Okay, the function of the erythrocytes is to carry the oxygen, right, and uh, and the CO2 to the lungs, right. The function of these erythrocytes is to carry the oxygen to the tissues and the CO2 to the lungs. Okay, they are anucleate. You guys already know that. Okay, and they lack every organelle. Okay, they do not have any organelle. They do not have any nucleus. Okay, they are biconcave in the shape so that the surface area could be increased, right? And they have a more surface area. Sorry, yeah, they have the more surface area than the volume. Okay, so that the rapid exchange of gases can happen. The lifespan is around 120 days. Okay, and the source of energy for the RBCs is the glycolysis only. They cannot undergo the TCA cycle because they do not have any mitochondria. Okay, so first they will go under the glycolysis, and then they will go under the what reaction? Lactic acid formation, right? And aerobic glycolysis, you will call it. Okay, they will also use the 10% in the HMP shed. Okay, very important. So this glucose, 90% will be used in the glycolysis and 10% will be used in the HMP shed. And what does this HMP shed forms?
NADPH.
NADPH.
NADPH and also nucleotides if required, but not by these cells, of course, right? Their membrane, they also contain the chlorine and the bicarbonate antitransporter, okay, which will throw out the bicarbonate and will take in the chlorine. Okay, you will call it the chloride shift. We will study that later in the respiratory section also, right? And this helps the RBCs to carry this CO2 to the lungs, right? So whenever you have the polycythemia, the levels of the erythrocytes will the level of these RBCs will rise, okay, and you will have the high hematocrit, okay. In case of anisocytosis, you will have the varying sizes of the these RBCs, okay. In case of poikilocytosis, you will have the varying shapes. So anisocytosis for the size and poikilocytosis for the shape, okay. Reticulocytes are the immature RBCs, and just like in case of neutrophils, whenever you have any infection, you will have the immature neutrophils in the blood, like the band forms, right? Whenever you have an acute blood loss or whenever you have a RBC's destruction, the bone marrow will try to compensate that by releasing the reticulocytes in the blood. Okay, so whenever you have the hemolysis, which is with the normal bone marrow functioning, right? You will always have the high reticulocyte count. Okay, very important. And these reticulocytes, they have this bluish color on the right gym staining, okay, which will represent the ribosomal RNA. Okay, just like a Dole bodies, which also contain this ribosomal RNA. That's why they're bluish, right? Similarly, these cells, the RBCs, and these cells, the reticulocytes, they will have this bluish color on the Simpson staining, and it is because of the ribosomal RNA. Both are because of ribosomal RNA, right? And out in that,
No, thank you.
okay. Then comes the platelets, also known as thrombocytes. Okay, that involved in the homeostasis. Okay, what is the difference between the homeostasis and the hemostasis?
Hemostasis is basically the clotting of the blood, stasis of the blood, while the homeostasis is maintenance of ECF environment.
Yes, exactly. When you maintain the environment, the temperature for say, you will call it a homeostasis. In case of hemostasis, you will prevent the leaking of the blood, will prevent the blood, right? It's just a term for the blood. Okay, the maintenance of the blood, the normal environment, right? So they are derived from the megakaryocytes. Okay, we have discussed that they have the lifespan of 8 to 10 days. Okay, whenever any kind of endothelial injury occurs, they will get activated, they will aggregate, and they will form a weak platelet plug. After that, the different platelets, they will be attached to each other with the help of fibrinogen. Okay, and now this fibrinogen will be converted into the fibrin with the help of the clotting cascade, right? And this helps in the formation of very strong platelet plug and these fibers, right? So they contain such dense granules, and you can remember them by the mnemonic CASH. Okay, they have the calcium, they have the ADP, they have the serotonin, they have the histamine, right? They also have 4F. Okay, you can remember them by the name of 4F. First is the von Willebrand factor VWF. Second is the fibrinogen. Third is the fibronectin. Okay, and fourth is the platelet factor 4. Okay, so 4F and the CASH. These are the granules in the thrombocytes or in the platelets. Okay, approximately 1/3 of the platelets they will be stored in the spleen, and whenever you have the splenectomy, all of that store will be entering into the blood. So at the time of the splenectomy, you will have the thrombocytosis also, right? Thrombocytopenia or decrease in the platelet function, it will cause a petechial rash. Okay, and it is because of the skin bleeding. You will see subcutaneous bleeding, and that can lead to the petechia, right? The von Willebrand factor, they will bind to the this glycoprotein 1b. Okay, and the receptors for the fibrinogen, this is a glycoprotein 2b3a receptor. Okay, so different platelets, they will bind together with the help of the fibrinogen. Okay, and the platelets have this glycoprotein 2b3a receptor. Okay, through which the fibrinogen will connect different platelets, right? And the platelets will be attached to the endothelium with the help of the von Willebrand factor, which attach to the platelets on the glycoprotein 1b receptors. Okay, whenever you give the patient thrombopoietin, they will have the stimulus. It will stimulate the proliferation of the megakaryocytes, so you can have a more platelets, right? And yeah, that's all about the platelets. Any doubt?
No, thank you.
Then the monocytes. Monocytes are nothing but the macrophages in the blood, right? And whenever these monocytes enter the tissues, they will become the macrophages. Okay, they have this giant kidney-shaped nucleus. As you can see, it has this curve-like structure, this thing. Okay, and that would be all about it. Important ones are the macrophages. Okay, their function is to phagocytose the bacteria or any other pathogen in the body, right? They will also digest the cellular debris, okay, and also the senescent RBCs. They're present in the spleen, they're present in the liver, okay, and whenever a damaged RBC come into the spleen or in the liver, they will digest the RBCs, right? So they can phagocytose the bacteria or the pathogen. They can phagocytose any cellular debris. Remember, at that time of third day of the inflammation, they will come at the tissue site, at the inflammation site, and they will start digesting everything in there, right? So they can digest the tissues of this, the cell debris, and they can also take the RBCs. Okay, they have the long life in the tissues. Okay, and they are differentiated with the help of monocytes. These monocytes, right? They will be activated by the gamma interferon. We have discussed that already, right? And they can also function as the antigen presenting cells. We have discussed that already, and they will present the antigen to the MHC2, right? And they are the important components of the granulomas, right? They will be converted into the epithelioid cells, right? And they will also form the giant cells, right? So a specific type of macrophages exist in specific tissues. For like in case of liver, you call them the Kupffer cells. In case of skin, you call them the Langerhans, these Langerhans cells, right? In the connective tissue, you call them the histiocytes, right? In bone, you can call them the osteoclast cells, right? And that's why the osteoclast cells, these are the multinucleated cells, right? Because many macrophages will fuse, okay, and they will form the multinucleated osteoclast cells in the bone, right? In the brain, you call them the microglial cells. Okay, they have the lipid A, okay, from the bacterial lipopolysaccharides, which will bind to the CD14 on these cells. And the CD14 is nothing but known as what receptor? Remember the CD14, which will activate the NF-kappa B. What does it known as?
A PAM?
PAM, it will recognize the PAM, but it is not known as PAM. It will recognize the PAM.
Macrophage?
It is a receptor in the macrophage, but what receptor? CD18 is also known as what name?
Integrin.
Which one? I mean,
Toll-like receptor. Toll-like receptor. Okay, you call them the toll-like receptor. Okay.
sorry, could you explain what you asked?
I asked you the name of CD14 receptors. What does this receptor known as, right? They will recognize a lipid A, like the PAM, that present on the macrophages, and you call them the toll-like receptors, right? They will activate the NF-kappa B further. Is that okay?
Yes, thank you.
And these receptors are involved in the septic shock. Okay, because they will cause a widespread release of this interleukin 1, 6, TNF alpha, right? And they're involved in the septic shock. So that's everything about the macrophages. Any doubt?
No, thank you.
Then comes the eosinophils. Okay. And if you guys go back to the macrobiology section, we have discussed how in case of any helminthic infection, you can have a high eosinophil count. Whenever you encounter a patient, okay, who is having this diarrhea type thing, okay, or any kind of a skin infection, okay, along with that, they're also having a high eosinophil count. You will always suspect the parasitic infection, or more specifically, I can say the helminthic infection, right? In every helminthic infection, you will have the high eosinophil count. They have a very large size, so they can easily phagocytose these parasites, right? And they also releases the major basic protein, and this major basic protein is a major toxin against the helminthic infection. Okay, and their bilobe nucleus, okay, they're filled with the large eosinophilic granules, and that's why you call them the eosinophils, as you can see on this figure, also on this picture. As you can see, these are all the eosinophilic granules, right? And they also shows the antigen antibody type interaction, the ADCC, okay. And in that case, you know, the IgA antibodies and the IgG antibodies, they will bind to the pathogen first. Okay, after binding to the pathogen, they will take the pathogen to the eosinophils, so that the eosinophils can phagocytose that pathogen, that parasite, and they also release the major basic protein. Okay, and they can release the histaminase. They can release the major basic protein, which is a helmintotoxin. Okay, and they also have the catenic proteins, which is not very much important. Okay, and they also have the eosinophil derived neurotoxin. Okay, and so just one thing which you need to remember about the eosinophils is that they are the major defense against the parasitic infection. Okay, and the IgG antibodies and the IgA antibodies, they also takes part in the parasitic infection. Whenever you have a GI infection, the IgA antibodies will get activated and they will take the pathogen to the eosinophils. Whenever a bloodstream infection occur with the helminths, okay, the IgG will get activated and they will take this helminth to the eosinophils. Okay, and just remember one thing about this major basic protein, which is the major toxin against the these helminths. Okay, So in what cases you can have a high eosinophilia? In the hypersensitivity reactions like the asthma, okay, in the parasitic infection, right? If you guys remember the Stokes disease in which you have the eosinophilic granulomatosis with polyangiitis, right? You will have the eosinophilia there also, okay? And remember the adrenal insufficiency we have discussed, you can have a high eosinophil count there also. In case of myeloproliferative disorders, because the myeloproliferation is there, the myeloid stem cells, right? So they can have the high eosinophilic count. In any allergic process like the asthma, you can have the high eosinophilic count. In the neoplasia, like the Hodgkin's lymphoma, because it releases the interleukin 5, right? This Hodgkin's lymphoma releases the interleukin 5, so you can have a high eosinophil count. Is that okay?
I have a question. Is there
Yes.
any role of IgE antibodies in helping eosinophils?
See, IgE antibodies are mainly involved in the this allergic responses, right? Very minor role they play in case of helminth infections, but the major role is of IgA and IgG antibodies.
No, not in case of helminthic infections. In case of asthma
Yeah,
or
in case of asthma, what's gonna happen? You will have the IgE antibodies, which will sensitize the eosinophils also. Okay.
so and it will destroy the cells by antigen-dependent cell mediated cytotoxicity.
Yes, exactly. Same by the
So,
ADCC, yeah. Same by the ADCC, they will destroy the tissues also.
okay, so the IgE does help eosinophils,
Yeah,
right?
exactly. Exactly.
Okay,
Just,
thank you.
just like the IgE and this IgG antibodies, the IgE will help also these eosinophils, okay? Okay.
Thank you.
Now comes the basophils. Okay, basophils are basically the cells which are in the bloodstream. Okay, and they contain the heparin, they contain the histamine. You guys know about the heparin, which is an anticoagulant. You guys know about the histamine, which is a vasodilator. Okay, and they're only present in the blood. Whenever they go to the tissues, they become the mast cells. Okay, and you will have the high basophilic count in the CML only. Please note that fact. Okay, in case of CML, you will have the basophilia. In case of Hodgkin's lymphoma, you will have the eosinophilia. Okay, and most of the IgEs, they either bind to the mast cells, okay, or they bind to the basophil cells. Okay, they are not circulating freely very much in the bloodstream. Okay, they are mostly binded to these two cells, the mast cells and the basophil cells. Okay, so now comes the mast cells, which are the major cells in the tissues, right? They mediate the local allergic responses, okay, and they originate from these the basophilic cells only, right? When what happens, they have the receptors for the for the FC portions of the IgE antibodies, right? So the IgE antibodies can bind to the mast cells with their FC portion, like that. Okay, like that they can bind to the mast cell, right? And yeah, whenever the C3A comes, whenever the C5A comes, right? Whenever any tissue trauma happens, right? Certain drugs can also cause that same thing. Okay. So what happens is, and uh, and this IgE antibodies. So whenever an antigen comes, right, and it bind to these IgE antibodies, because the antigens are kind of very big size. Okay, so multiple IgE antibodies can bind to the same antigen, right? This is known as a cross-linking. Okay, when many antibodies, many IgE antibodies bind to a same antigen, you call it the cross-linking. And because of the cross-linking, you can say the receptor aggregation is occurring. All of the RBCs which are present here, right, which are present here, they will all migrate to this antigen, right? And as a result, the receptor aggregation will happen. Now, because of this receptor aggregation, right, and then the cross-linking, these two steps, because of these two steps, the degranulation of the mast cells will take place. Okay, first thing is the receptor aggregation, and the second step is the cross-linking. Because of two steps, okay, the degranulation of the mast cells will occur. Okay, the C3A complement, the C5A complement, and certain drugs also, like, remember the name of the drugs which can cause a direct mast cell degranulation?
Morphine.
Yeah. One thing is the
Vancomycin.
morphine and
Vancomycin.
the vancomycin. Yes, morphine and the vancomycin, or you can say the opiates, right? The opioids and the vancomycin, they can cause a direct muscle degranulation also, right? So IgE antibodies, apart from IgE antibodies, tissue trauma, C3A, C5A, or the vancomycin or these opioids, okay, they all can cause the direct muscle degranulation. Okay, remember these two steps. One is the receptor one is a receptor aggregation and second is a receptor cross-linking. You can have the mast cell degranulation. After the degranulation, these mast cells will release the histamine, heparin, tryptase, and tryptase is the marker of the the cell activation. Okay, whenever you have a mast cell activation, you will have the high level of tryptase. And if you guys remember one disorder by it in the GIT,
Systemic mastocytosis.
yeah, systemic mastocytosis. In case of systemic mastocytosis, you will have the KIT receptor mutation, and as a result, hyperproliferation of the mast cells, and they will release large amount of histamine and large amount of tryptase. You will check the level of tryptase to get the activation, to get the idea of the activation of mast cells, right? So whenever you have a mast cell degranulation or the activation of mast cells, you will have the high level of tryptase, which you can easily measure in the blood. Okay. Yeah. So they're mostly involved in the type 1 hypersensitivity reaction, right? And the cromolyn sodium, which is used in the treatment of asthma, it prevents the mast cell degranulation, right? The vancomycin, opioids, sometimes a radio contrast dye also, they can cause the IgE independent mast cell degranulation, right? And yeah, that would be it. Any doubt?
I
Any
have
doubt?
one question. The drug which is omalizumab, which is given for asthma,
Yes.
it binds to the antibody or to the receptor of the antibody?
So the antibody,
Okay. Yeah. Okay. Got it. Thank you.
they're against the antibody. They will destroy the antibodies. Okay.
Okay. Yeah. Thank you.
Okay, now comes the dendritic cells, which are the highly antigen presenting cells, highly phagocytic antigen presenting cells. Their main function is the antigen presentation only. Okay, and these are the link between the innate and the adaptive immunity. Okay, they expresses the MHC class 2 and the Fc receptors on their surface also. Okay, so nothing much about these cells. Just they have only one function, which is the antigen presentation. Okay, nothing much more about that. Then comes the acquired immune system. Okay, the lymphocytes. Okay, first of all, you have the lymphoblast, and the lymphoblast can form the B cells, the T cells, and the NK cells. The B cells and T cells, they are the part of this adaptive immunity or the acquired immunity, while these NK cells, they are the part of innate immune system, right? And they have a very large nucleus and a very small amount of pale cytoplasm, as you can see. A very large nucleus and a small amount of cytoplasm. These are the hallmark feature of lymphocytes. So first talk about these NK cells or the natural killer cells. Okay, that the receptors are very important. CD16 and CD56 are the two receptors found on the NK cells. The CD16 receptors is for the Fc portion of the antibodies. The same receptors can also be found on the macrophages. Every cell which takes part in the ADCC, right, they all have the CD16 receptors for the Fc portion, right? But a more special, this CD16 is kind of a sensitive receptor, okay, but a non-specific type, right? But the CD56 is a very specific receptor for the NK cells, okay? The function of these NK cells is to identify those cells who have lowered down their MHC1 levels or the MHC1 receptors, right? So those cells who are, who become virally infected or they become, the tumor cells, they will always lower down the MHC on their surface, right? And now, if the MHC1 is lower down, then the CD8 cells cannot recognize these kind of cells. Now comes the NK cells, okay? These NK cells will recognize those cells who have lowered down the MHC, right? And after recognizing these cells, they will release the perforin and the granizymes. Okay, they have the large granules which contain the perforins and the granizymes, just like the CD8 lymphocytes. The perforin will cause the increase in permeability of the cell membrane, right? And then the granizymes will enter into the cell and they will activate the apoptotic pathway. It will cause the apoptosis. Okay, so Yeah, that would be all about it. So they just identify the infected cells and the tumor cells, right? And you have the CD56, which is very specific, and the CD16, which is kind of non-specific marker. Okay, macrophages, they can activate the NK cells by releasing the interleukin 12. Okay, and in response, these NK cells will release the interferon gamma to activate the macrophages. Similar, the reaction will also present in the CD4 and the macrophages also. To activate the CD4 cells, the macrophages will release interleukin 12. Okay, after activation, the CD4 cells will release this interferon gamma and the interleukin 2. Interleukin 2 will cause the proliferation of the cells, and interferon gamma will activate the cells. Is that okay?
Yes.
Remember only 3-4 things. First is a receptors. Second is a type of cells they identify, and what does they do when they identify the cells. Then the B cells, okay, they are a part of your humoral immune response. Okay, when they get activated, they will be converted into the plasma cells, and the plasma cells then can release all these antibodies, right? So these B cells, they do have the antibody on the surface, okay, and the antibody on the B cells, they work as a receptor, okay, for the antigen identification. Once the B cells get activated, they will be converted to the plasma cells, and now the same receptors can be secreted from the cells. Okay, you need to look the location of the B cells. They are formed in the this bone marrow, and after the bone marrow, they can go to the lymph nodes. In the lymph nodes, they found at the cortex portion in the follicles. Right. In case of spleen, they're found in the white pulp. Okay, very important. And they have receptors like C20, 21, and the 19. And what is the receptor for the Epstein-Barr virus?
21.
Receptors for 21. Yes, do remember that. Okay. And around 80% of the B lymphocytes, they are present in the lymph nodes, and only 20% of the B lymphocytes are in the circulatory system, right? While around the 80% of the T lymphocytes, they are found in the circulation, and only 20% of the T cells are found in the lymph nodes. So they're kind of opposite, right? And the B lymphocytes, they can also work as the antigen presenting cells. Remember two types of antigen recognition. One is a thymic dependent, and second is a thymic independent, right?
Yeah.
So if the thymic independent activation occur, right, in that case, these B cells will release only the IgM antibodies, right, and they will activate it by the polysaccharide antigen. In case of thymic dependent activation, they will first present the antigen, the protein antigen, to the CD4 cells, and then the CD4 cells will activate the B cells to release more antibodies like IgG and other types, okay, other specific antibodies. So that two type of activation, please remember. Surface markers, please remember what immune system they are part of, remember that, and where the location the B cells found, remember that, okay. Then comes the T cells. They are the part of a cell, the cellular immune response, which is the acquired immune response, of course, right? They are of two types, either the CD8 cells or the CD4 cells, right? And both of the CD4 and the CD8 cells, they have a CD3 common, right? Very important. And the CD8 cells will recognize the MHC1, and the CD4 cells will recognize the MHC2, right? They also have the CD28, okay, which is a co-stimulatory signal, which is necessary for the T cell activation. After the binding of MHC1 or the MHC2, okay, with the T cell receptors, okay, the CD28 and the B7 interaction is must. The B7 is present on the antigen presenting cells, and the CD28 is on the T cells, right? They will recognize these things. The secondary signal will occur, and that will activate the T cells. Okay, and yeah, they're formed in the bone marrow, and they're maturate and they maturate in the thymus, right?
Yes.
And out. Now comes the plasma cells. We have discussed that already. The B lymphocytes, whenever they get activated, okay, they will start secreting the antibodies by converting into the plasma cells, right? And the very important part is they have the clock phase chromatin. When you look in the nucleus, you will have the arrangement of the chromatin in the form of a clock phase, like in the periphery, like that, okay? Apart from that, They also have a very lightish portion in the cytoplasm. If you can see, guys, let me zoom. If you can see, they have a very lightish region in the cytoplasm, right? And this area is known as the Golgi apparatus. This area is kind of rich in the because these cells are the secretory type of cells. Okay, they have to secrete the proteins, right? And you guys already know that every protein which is formed in the endoplasmic reticulum and the Golgi body, it will be ultimately secreted from the cells, right? So these cells have to be rich in the Golgi apparatus. So they have a very well-developed endoplasmic reticulum and a very well-developed Golgi body, right? And this could be appear as a very lightish portion in the cytoplasm. So a very hallmark feature of the plasma cells is this part. Okay, and these cells, they are only found in the bone marrow. They do not circulate in the peripheral blood smear. Very important. So if the step one asks you about the multiple myeloma, which is a tumor of bone marrow, and they ask you which cells you will find on the peripheral blood smears, is that these cells, the plasma cells? Can you find them in the on the PBS? In case of multiple myeloma, no, you can never, right? So what cells you will found in the PBS? Yeah, no. What you will found on the PBS in case of multiple myeloma? The Rolex formation. Remember the linear aggregation of the RBCs, stacking of the RBCs upon each other, right? The Rolex formation.
Yeah, yeah.
Okay, so if the step one asks you what you will see on the PBS, please answer only the Rolex formation or the RBCs. If they ask you what you will found on the bone marrow, then you will answer the plasma cells. Okay, because the step one will give you both the options, the Rolex formation and the plasma cells. So depending upon the site, you can check whether the plasma cells are present and whether the Rolex formation is present. Okay, and they are increased in case of multiple myeloma or any other plasma cell dyscrasias. Okay, any doubt?
No, thank you.
So that's about the plasma cells. Now, the different type of hemoglobin. Okay, first is a normal adult type, which is HbA1. Okay, and it consists of alpha chain and the beta chain, right? Then the fetal hemoglobin, which is AF. Okay, and it consists of alpha chain and the gamma chain. Okay, then you have the sickle cell type, in which you either have a sickle cell trait or you have a sickle cell disease. If you have a sickle cell this trait, then you have one normal type of hemoglobin, as you can see, and one abnormal type. Okay, and because in case of sickle cell anemia, this glutamic acid will be converting into the valine, right? And this valine consists of positive charge. Okay, so as you can see, if I take an anode here, if I take the anode here and the cathode here, which means a negative charge here and a positive charge here, okay, then because the hemoglobin consists of glutamic acid, which is a negative one, right? So this part will repel the hemoglobin and this part will attract the hemoglobin, right? So hemoglobin will travel from minus charge to the plus charge, right? In case of normal newborn hemoglobin, they have the alpha chain and the beta chain, right? So, this type of structure is formed in them. Okay, very important. They have some amount of the normal hemoglobin, which is adult type hemoglobin, and they have some time of fetus hemoglobin, right? In case of a sickle cell anemia or a sickle cell trait, because the hemoglobin chain will be replacing with the glutamic acid and the chain will be replacing with the valine, right? And it consists of positive charge. So as you can see, the positive charge will repel it. Okay, so now the hemoglobin will travel this less distance. It will stop here. Okay, and the normal one will go to here, right? In case of a sickle cell disease, because you do not have any normal hemoglobin, okay, so every hemoglobin, the sickle cell type hemoglobin will stop here at a very early type, right? Then you have the HbC type trait, okay, in which this hemoglobin will stop at a more early stage, okay. Then you have the disease, okay, And yeah, and then you have this combined type in which you have the HBC disease as well as a sickle cell, right? So the hemoglobin will stop at this S location and as well as the C location. Okay, so step one can give you certain scenarios in which they will give you a reference values, like the value of normal hemoglobin, where does it stopping, the value of HBC hemoglobin, where does it stopping, and they will give you some this unidentified type of hemoglobin, okay, the location of that, and then you need to identify whether it is a normal type hemoglobin or the adult type or the fetus type or the sickle cell type, and that's why you need to remember this whole selectophoresis. Is that okay?
Yeah, yeah.
What does this HBC disease is? Anyone? No? In the HBC disease, you will have the conversion of glutamic acid into the lysine, right? And yeah, one thing I got confused. In case of glutamic acid to the valine, valine is kind of neutral charge. Okay, it is not positive. Valine is a neutral amino acid, right? So it will travel less distance. In case of HBC disease, because the glutamic acid is converting into a lysine, and lysine is a positively charged amino acid, right? It is a basic amino acid. So as you can see, the positive will repel each other, right? So this HBC type of hemoglobin, it will stop at a very early stage, right, of lactophoresis. Okay. So do remember the glutamic acid and the valine and the glutamic acid and the lysine, right? Any doubt on the lactophoresis?
What were you saying about HBC disease?
In case of HBC disease, you will have the conversion of this glutamic acid into the lysine. Glutamic acid is negatively charged and the lysine is positively charged, right? So because the positive repel each other, you know, so that's why this HBC type of hemoglobin, it will stop here only. It won't go any further, right? In case of a sickle cell disease or a sickle cell trait, because a hemoglobin, the glutamic acid will be converting into the valine, which is neutral amino acid, not a, it do not have any charge. It is neutral, right? So, the hemoglobin can be travel further more than the HBC type and it will
Yeah.
stop here.
Okay. Yeah. And what were you asking about HBC disease? Like what it is?
Yeah. That's the thing I was asking about the HBC. What is it? What's going to happen in the HBC disease? The pathology behind it, right?
Yeah, there's extravascular hemolysis and those crystals get deposited.
Yeah, these are the complications, of course. But this HBC disease is kind of less severe than the sickle cell anemia. And can anyone tell me why?
Sickling is absent
Why?
because of different amino acid. Like one was like predisposing to sickling during deoxygenated state.
And why is that case?
Not sure about the details.
See, in case of sickle cell anemia, you can imagine, see, in a normal hemoglobin, you were having this you were having this negative charge, right? And the negative repel each other. So different hemoglobins, different chain of hemoglobins, they will be repelling each other. Is that okay? Because of negative charge, right?
Yeah.
In case of sickle cell trait or a sickle cell disease, because this negative charge is now lost, so these chains can now come closer, right? And as a result, sickling can happen, right?
Right.
In case of a HBC disease, because this negative charge is getting replaced with the positive charge, right? But it still has the charge which can repel each other, right? The positive
Yeah. Yeah.
charge. So that's why the sickling won't happen.
Okay.
Okay.
Yeah.
So
Yeah.
that's why the HBC disease is kind of less severe than the sickle cell disease, because sickling won't happen in that case.
Yeah. Okay. Thank you.
Okay. So any other doubt on this page?
No, thank you.
Okay. So we will take a short break here. Okay. And then start the platelet formation. The homeostasis. Okay. The hemostasis. Okay.
Yes.
Just give me a second. So whenever the endothelial injury occur, okay, after the injury, first thing would be the vasoconstriction happens. Okay, and the vasoconstriction will decrease the blood flow in that area so that the blood loss could be prevented. Okay, because of the endothelial injury, the collagen which is present in the subendothelial region will be exposed. Okay, and when this collagen is exposed, the von Willebrand factor, which is made up by what cells? Anyone?
Cells and platelets, weevil pellet bodies.
Vibroplasty bodies, yes. So the vibroplasty bodies will form this von Willebrand factor. Okay, it will bind to the collagen which is exposed after the endothelial injury. Now, when this VWF factor bind to the collagen, okay, it has the binding with the glycoprotein 1b receptor, which is found on the platelets. Right now, this von Willebrand factor will bind to the glycoprotein 1b receptors on the platelet, and as a result, this platelet is now attached to the endothelium. Right now, when the multiple platelets attach to the endothelium, the platelets will also have the receptors, which are the glycoprotein 2b3 receptors. Okay, now this fibrogen will bind to this glycoprotein 2b3 receptors, and now multiple platelets could be attached to each other, as you can see. Okay, this platelet, it also has a glycoprotein 2b receptors. This platelet has the same receptors. The fibrogen will bind to these receptors and will attach multiple platelets together. Okay, so the first thing will be the injury. After the injury, the endothelium is exposed. The vasoconstriction has happened. The von Willebrand factor will be attached to the endothelium, right? The von Willebrand factor will also attach to the platelets with the help of glycoprotein 1b receptors, right? After that, what happens is, after the binding, the ADP will be released from the platelets. Remember, the platelet had the cache, the calcium, ADP, serotonin, and the histamine, right? So the ADP will be released from the platelets. The ADP will bind to the receptors, which are P2Y12 receptors, right? After the binding of the P2Y12 receptors, the translocation of the glycoprotein 2b3 receptors happen at the cell surface, as you can see. Just like remember GLUT4 receptors, the translocation will happen after the binding of insulin.
Yeah.
Similarly, the ADP will bind to the P2Y12 receptors, and now the translocation of these receptors can happen to the surface. When the translocation happened, the fibrogen which is circulating in the blood, and the fibrogen is also released by the platelets itself, right? They will bind to the glycoprotein 2b3 receptors, and now multiple platelets could be attached to each other, right? Now, this TXA2, okay, it also released from the platelets, okay, by the arachidonic acid metabolism pathway, okay, which will promote the more this aggregation of the platelets, right? This TXA2 will promote the aggregation of the platelets, right? So that's how the multiple platelets attach to each other. Now you have two type of the factors, which the first one is the pro-aggregating factors, and the second one is the anti-aggregation factors. The pro-aggregation factors includes the TXA2, which is released by the platelets. Okay, second is the decrease in the blood flow by the vasoconstriction, and third is a platelet aggregation itself, right? The anti-aggregation factors includes a prostaglandin I2, right? The nitric oxide, which causes a vasodilation also, right? And the increase in the blood flow, okay, and the decrease in the platelet aggregation, right? Very important. So now this plug is known as the weak platelet plug. The weak platelet plug, it contains the fibrinogen. Now the clotting cascade will start it, okay, and this clotting cascade function is to form the fibrinogen. Is to form the fibrin from this fibrinogen. Okay, the whole clotting cascade, it will form the fibrin from this fibrinogen, so that a more a tightened binding can occur. A strong platelet plug can form, right? So you have certain drugs and you have certain diseases in which the weak platelet plug formation is inhibited. You call them the antiplatelet drugs. Okay, and the first drug includes the ADP receptors inhibitor, which are the P2Y12 receptor inhibitors, and these are known as the clopidogrel, the plasogrel, and the ticlopidine. Okay, they have the grill in their name. Okay, the clopidogrel, the plasogrel, and the ticlopidine. These are the drugs which inhibit the P2Y12 receptors. right? Second type of drugs are the drugs against the glycoprotein 2b3 receptors, which are the apixaban, actifibutide, and the tirofiban. Okay, and these drugs inhibit the glycoprotein 2b3 receptors. Then you have certain drugs which inhibit the TXA2. Okay, which inhibit the after inhibition of this TXA2, you can inhibit the platelet aggregation, and you have the aspirin for that, and that's why the aspirin also has the antiplatelet activity, because it inhibits the COX enzyme so that the arachidonic acid can never be converted into the TXA2. Okay, so remember these three drugs, the three category of drugs, right? And you have certain diseases also which causes the prevention of this weak platelet formation. First, you have the Bernard-Soulier syndrome, in which you have a deficiency of the glycoprotein 1b receptor. Okay, now because of deficiency of glycoprotein 1b receptor, these platelets can never bind to the von Willebrand factor, right? And yeah, the second one is the von Willebrand disease, in which you have the absence of the von Willebrand factor, and as a result, the platelets again cannot bind to the endothelium. So how you can differentiate between the Bernard-Soulier syndrome and this von Willebrand deficiency? Anyone?
We can give plasma and see.
Yeah, exactly. Once you give the plasma, because the plasma contains the VWF factor, the von Willebrand factor, right? If you give the patient plasma and it contains the von Willebrand factor, and if the aggregation happens, that means the patient was deficient of von Willebrand factor. But even after giving the patient plasma, this aggregation does not happen. That means the defect is in the platelets, not in the plasma, not in the protein, right? The von Willebrand factor will be absolutely normal, and the defect will be in the platelet itself. Is that okay?
Yes.
Okay. Now, third, you will have this Klansman thrombosthenia. Okay, you have the Klansman thrombosthenia. Just give me a second. Okay. So you have this Klansman thrombosthenia, in which the platelets can attach to the endothelium, but the platelets cannot attach to each other, right? So the three disorders: the Klansman thrombosthenia, the von Willebrand deficiency, and the Bernard-Soulier syndrome. Okay, and the three category of drug. Okay, one are the ATP receptor inhibitor, second are the glycoprotein 2b3 receptors inhibitor, right? And third is the aspirin. Any doubt on this page?
No, thank you.
Okay. And yeah, how you can differentiate between the Glanzmann thrombosthenia and these disorders, the von Willebrand deficiency and the Bernard-Soulier syndrome? This is by the restostatin test. Okay, if you give this drug, because it activates the von Willebrand factor to bind to the glycoprotein 1b. Okay, after giving this drug, if the platelet aggregation happens, okay, that means that the glycoprotein 1b receptors and the von Willebrand factor are absolutely normal. It is a deficiency of these receptors or the mutation of these receptors. Okay, if even after giving the patient restostatin, the aggregation won't happen, that means the patient might be deficient, in these receptors. Sorry, that means a patient will be deficient in the these types, the von Willebrand factor or the glycoprotein 1b deficiency. Is that okay?
Yes, yes.
You give the patient restostatin. If the aggregation happens after giving the restostatin, that means the deficiency of this happen, right? And if the aggregation does not happen, that means the patient will be deficient of this von Willebrand factor. So it depends. And this von Willebrand factor is also a carrier of factor 8. Okay, very important. So now you have the platelets which contain the fibrinogen, okay, and it forms the weak platelet plug. Now this fibrinogen must be converted into the fibrin, which is the activated form, and this is done by the coagulation cascade. Okay, you have two type of activation. One is by the tissue itself, by the damage of the tissue, which is the extrinsic pathway. Okay, and second is by the platelets itself, and you call them the intrinsic factor. The intrinsic pathway. Okay, so for the intrinsic pathway, you have the factor 12. Okay, which will convert it to the activated factor 12. Okay, it will convert the factor 11 into the activated form, which will activate the factor 9 into the activated form, right? Ultimately, this factor 9 and factor 8, which is activated, it will convert the factor 10 into the activated form. Okay, then the factor 2 will be activated along with the factor 5 and factor 10. This factor 5 and factor 10 will combine to activate the factor 2 into the factor 2, which is a prothrombin. Okay, this prothrombin will be converted into the thrombin. Now, once the thrombin is formed, it will convert the fibrinogen into the fibrin. And now the aggregation can happen, right? And the fibrin meshwork can also be formed. Is that okay? Second type is the extrinsic factor pathway, in which uh, because of the damage of the tissues, they will release a factor 7, right, which will be activated into the factor 7a, which is activated form. Okay, you have the tissue factor also. Now, tissue factor along with the factor 7 activated, it will convert the factor 10 into the factor 10 activated. So the ultimately, what you need is the activation of this factor 10. Okay, by the intrinsic pathway and by the extrinsic pathway, you are ultimately activating the factor 10. And this factor 10 will convert the factor 2, factor 2 will convert the factor 1. Okay, you just have to go reverse. 12, 11, 10 will be here, 9, 8, right? The 7 is here, the extrinsic pathway, ultimately 2 and 1. Is that okay, the pathway?
Yes, yes.
Okay, now see, you have certain drugs, okay, which can interfere with this pathway and can inhibit the coagulation. Okay, initially you have studied about the antiplatelet drugs. Okay, now in these drugs, those drugs which inhibit this pathway, they are known as the anticoagulant drugs. Okay, first you have the natural anticoagulant, which are the protein C and protein S. It is released by the liver and they inactivate the factor 8 and factor 5. See, the factor 8 and factor 5 are required for the activation of factor 10 and factor 2 respectively, right? The function of protein C and S is to inhibit these factors. Then you have certain anticoagulants like the heparin, okay? Heparin and the low molecular weight heparin, right? And the direct thrombin inhibitors, they will inhibit the factor 2, as you can see here, okay? Heparin, the low molecular weight heparin and the direct 10A inhibitors, they can also inhibit the factor 10. So the heparin can inhibit both the factor 10 and the factor 2. Okay, while the low molecular weight heparin, they mainly inhibit the factor 10, but at some amount they can also inhibit the factor 2. Okay, then you have the separate thrombin inhibitors and the factor 10A inhibitors. Okay, the factor 10A inhibitors known as the apixaban, they all have the name XA, this term XA in their name. Okay, for the factor 2A inhibitors, okay, you have this agatropine, the bivalirudin, and the dabigatran. Okay, they have this name in them. So yeah, so that's about the drugs. Okay, so this is the pathway for the coagulation. Now you also have the anticoagulation pathway, in which once this when this plug is formed, okay, once this meshwork is formed, it will be degraded also, right? And this is done by the thrombolytics. Okay, you have the plasminogen in the blood. Okay, this plasminogen with the help of TPA, okay, it will be converted into the plasmin. Okay, and once the plasmin is formed, this plasmin can solubilize these fibrin meshwork, and as a result, the degradation of this fibrin can happen into the D dimer. Whenever you have the protein, whenever you have the fibrin plug formation, okay, this fibrin plug will also be degraded, and whenever the degradation of this fibrin plug occurs, okay, the D dimers will be released. So by looking at the D dimers level, you can check the activity of this plasmin. Is that okay?
Yes.
Now certain drugs are there which can activate this pathway. Okay, and these drugs are known as the thrombolytics. Okay, it includes the alteplase, the retiplase, streptokinase. Okay, these are three major ones. Okay, then you also have certain drugs which inhibit this pathway and promote the coagulation, and these are the aminocaproic acid and the transaminic acid. And you use these drugs whenever the toxicity of the thrombolytics happen. Whenever the patient is having any hemorrhage because of this thrombolytics, you will give the patient these drugs, the aminocaproic acid and the transaminic acid, which inhibit the fibrinolytic pathway. Is that okay?
Yes.
And you also have the link between the coagulation pathway and the kinin pathway. Okay, you have the high molecular weight kinin, okay, which with the help of this enzyme, which is a kallikrein, it will be converted into the bradykinin. And you guys know the function of bradykinin, it will cause the vasodilation, it will increase the permeability, and it will cause the pain also, right? Now, you have one enzyme, which is the C1 esterase inhibitor. Remember the C1 esterase inhibitor, it can lead to the angioedema if it becomes deficient,
Yes.
right?
Yes.
The other function of the C1 esterase inhibitor is to inhibit this kallikrein, okay, and to inhibit the factor 12 and the factor 11 also, okay, so that in the case of deficiency of the C1 esterase, what's going to happen, you will have the high level of kallikrein, okay, it will convert more high molecular weight dyskinogen into the bradykinin, so that more bradykinin could be formed, and as a result more vasodilation, more permeability, more pain can occur. And that is the reason why in case of C1 esterase inhibitor deficiency you are having the angioedema, because of the vasodilation and vasopermeability. Is that okay?
Yeah.
So whenever you have the coagulation, whenever you have the inflammation, okay, you can have a high level of kallikrein, you can have the high level of this factor 12 activation, right? And yeah, that is it. And whenever you encounter a patient having a very high level of PTT, see this pathway, just measure the PTT, okay, and this pathway measures the PT. The PT is known as the prothrombin time, okay, and this APTT is known as the
Activated partial thromboplastin time.
yes, the partial thromboplastin time. Okay, so for the PTT, you will measure this extrinsic pathway. Okay, with the PT, you will measure the with the PTT, you will measure the intrinsic pathway. With the PT, you will measure the extrinsic pathway. Whenever you have a deficiency of any of the clotting factor in this pathway, you can have a raised PTT. Whenever a deficiency occur in this extrinsic pathway, like the factor 7 deficiency, you can have a raised PT. In case of a deficiency of these clotting factors, which means an increase in the APTT, okay, you can have a decrease in the kallikrein formation. Okay, that's how these two pathways are linked together. Okay, very important. And yeah, in case of hemophilia A, you will be having a deficiency of factor 8, right? And when a deficiency of factor 8 occurs, the intrinsic pathway is inhibited and you will have a high level of APTT, right? In case of hemophilia B, you will be having a deficiency of factor 9, which is also a part of intrinsic pathway, so that you can have a high level of APTT again. In case of hemophilia C, you will be having a deficiency of factor 11, right? And again, you will have the high level of APTT. Is that okay?
Yeah, I have one question.
Yes.
Over there, you said something regarding the levels of kallikrein will be elevated if there's increase in PTT or something. What was that?
In case if you are having a deficiency of this pathway, see these two pathways are linked. Whenever you have a clotting cascade occur, okay, it will also activate this pathway. Whenever you have an inhibition of this pathway, it will also inhibit this wala pathway also, this pathway, the kinin cascade also, right? So in case if you are having a deficiency of the clotting factors in this pathway, then it can also inhibit the kinin cascade, right? So in a patient who is having a high level of APTT, which means a deficiency of these clotting factors, they can also have a decreased formation of kallikrein. Is that okay?
Yeah. Okay.
That is how these two pathways are linked.
All right. Okay. Thank you.
Okay, and all of the clotting factors in these pathways that you've studied, they all are synthesized in the liver, except one factor, which is a factor 8. Okay, this factor 8 will be synthesized in the endothelium and it will be stored in the von Willebrand factor. Is that okay?
Yes.
Note that fact also, right? Very important. Every protein will be synthesized in the liver except the factor 8. It will be synthesized by the endothelial cells and it will be stored in the von Willebrand factor. Very important. Now, once the fibrin is activated, okay, and the aggregation is happened, it requires the factor 13 now. Factor 13 will get activated by the thrombin again, and this factor 13 will convert this fibrin into the fibrin meshwork. Okay, so without factor 13, you still cannot have the meshwork. Okay, and it also requires the calcium. Okay, that is the other thing. So just remember the drugs, where the drugs are acting, what does they cause, either the increase in PT or the increase in APTT, right? And yeah, that would be it. Does anyone know the function of this heparin? How does this work? The MOA of this heparin? How does it inhibits the factor 10 and the factor 2? Anyone? No? See, this heparin actually binds to the antithrombin 3. Okay, and the function of the antithrombin 3 is to bind the factor 10, factor 2, right? And this mainly these factors. Okay, although it can bind to other factors like the factor 7, factor 11, factor 12 also, but the major ones are the factor 10 and the factor 2. Now, once the heparin binded to this antithrombin 3, it will activate the antithrombin 3 to bind to the factor 10 and to the factor 2. And as a result, this heparin is inhibiting the factor 10 and the factor 2. Okay, similarly, the low molecular weight heparin, it can activate the antithrombin 3 and make it bind to the factor 10 mostly, and in a very minor amount to the factor 2 also. And that's how this low molecular weight heparin can inhibit the factor 10 majorly and factor 2 minorly. Is that okay?
Yeah.
That is a mechanism of action of the heparin and the low molecular weight heparin. Don't forget that. Now comes the vitamin K dependent coagulation. You have the liver. In the liver, you have the synthesis of clotting factors like 2, 7, 9, 10, protein C and protein S. Okay. Now, once whenever they are formed, they are in the immature form and they need to be maturated. Okay, and the carboxylation step is there, okay, to mature them. Okay, and this carboxylation step requires the vitamin K. And you have to note that the oxidized vitamin K is the inactivated form of vitamin K, and the reduced vitamin K is the activated form of the vitamin K. And you require the enzyme epoxide reductase, which will reduce the vitamin K into the activated form, right? So with the help of this enzyme, the epoxide reductase, the vitamin K will become activated. Now you have the enzyme, which is the gamma glutamyl carboxylase, right? And this enzyme will use the vitamin K to cause the carboxylation of these proteins, these clotting factors, to make them mature, right? So in case if you give the patient warfarin, and warfarin is an inhibitor of this epoxide reductase, okay, it will inactivate the vitamin K so that this carboxylation step is inhibited, right? So you will have a deficiency of factor 2, factor 7, factor 9 and 10, and the protein CS in case of warfarin deficiency. In case of warfarin use. Is that okay?
Yeah.
Now you need to know the time, the T half of these factors. Okay, the shortest T half is of factor 7. Okay, and the longest T half is of factor 2. After the factor 7, the shortest half-life is of is of this protein C and protein S. So what happens whenever you give the patient warfarin? Okay, this protein C and protein S will be inactivated, at a much early stage than these protein 2 and then the protein then the factor 2, factor 9 and the factor 10, and as a result a transient hypercoagulable state is formed while giving the warfarin. Okay, because when you give the warfarin, you have the shortest half-life of factor 7 and then the protein C and S. So the protein C and S will be inactivated much earlier than the factor 2, factor 9 and factor 10, and as a result a transient hypercoagulable state is formed whenever you give the patient warfarin. And that's why you need to give the patient heparin also, okay, to prevent this hypercoagulable state. Is that okay?
Yes.
Yeah.
Note that fact also. So yeah, and the vitamin K will be formed by the enteric bacteria. The neonates, they lack the enteric bacteria, and that's why you need to give the patient a newborn vitamin K injections, right? Very important. And that would be it about. So once the clotting factors activate the fibrin, they will form the fibrin, as you can see here. Okay, and it is done by the thrombin only, which is a factor 2. And this thrombin, it also activates the antithrombin pathway. And the antithrombin is the protein, okay, which is involved in the inactivation of these activated factors. It will cause the inactivation of the thrombin, factor 7 activated, factor 10 activated, factor 9 activated, factor 11, and factor 12 activated. Okay, so whenever you have an activation of thrombin, it will inhibit itself by the antithrombin pathway. It will inhibit the factor 10 by the same pathway, right? And that's how the heparin works. Heparin will activate the antithrombin C and make it bind to the protein and make it bind to a thrombin and the factor 10. That's how it inhibits this coagulation. Okay. Whenever you have the protein C and protein S, it will inactivate the factor 5 and the factor 8 so that the clotting cascade could be inhibited. Okay. Any doubt on this coagulation cascade?
I have one question.
Yes.
You had said that antithrombin pathway also activates factor 2, but over here it is
Inactivate.
it
Inactivate.
inactivates factor 2, but over here it is not. It hasn't been mentioned. So, like, is there any like
Factor 2 thrombin.
Okay. Sorry. Yeah. Sorry.
Yeah. Don't
Thank
worry
you.
about that.
Thank
Okay.
you. Yeah.
And in case if you have a mutation in the factor 5, which is a disorder known as the factor 5 laden, okay, this factor 5 will become resistant to the inhibition by the protein C and S. And as a result, these patients has a hypercoagulable state also, right? Very important. The factor 5 laden is a scenario in which the factor 5 will become resistant to the inhibition by the protein C and protein S. And as a result, the patient will have a hypercoagulable state. They will have a recurrent episodes of deep vein thrombosis. They will have a recurrent pregnancy loss and other things also. TPA can be used as a thrombolytic because you guys know that TPA will activate the plasminogen into the plasmin, which will convert the fibrinogen into the D dimers, right? So very important to note. But just remember the factor 7, it has the shortest half-life, and the factor 2, it has the longest half-life. Step 1 can ask you this facts also. Okay, so we are done with the physiology. Any doubt up to there?
No, thank
No?
you.
Okay, now let's discuss the different morphology of RBCs, the different shapes of the RBCs. One is the acanthocytes, okay, and these are known as the spur cells, okay. They have these irregular spikes on the RBCs. And if you guys remember the A beta lipoproteinemia, in which you have a deficiency of lipoprotein, apolipoprotein B100 and the B48, I have mentioned that the patients can also have the acanthocytosis, right?
Yes.
What other symptoms the patient will have in A beta lipoproteinemia other than the GI symptoms?
Fat malabsorption.
Other than the GI symptoms, the diarrhea will be there, the fat absorption will be there, malabsorption, and the deficiency of vitamins is there. Other than that, one is the acanthocytosis. Other one,
Ataxia.
ataxia because of vitamin E deficiency. Yes.
Yeah.
Any ocular symptom? Retinitis pigmentosa. Okay.
Yeah.
Don't forget that retinitis pigmentosa is also present in the A beta lipoproteinemia, right? So this is acanthocytosis in which you have irregular spikes on the RBCs. It is seen in any kind of liver disease, also in the A beta lipoproteinemia. Then you have the echinocytes known as the Burr cells, in which you have a regular spikes. All of the spikes are of same size, okay, and or you can say a uniform projection is there. They are seen in the end stage renal disease. Very important. They are seen in the end stage renal disease as well as in the hemolysis, like in case of pyruvate kinase deficiency, in which you have a hemolytic anemia. Okay, you can have the Burr cells. In case of any liver disease, also you can also have these Burr cells, right? Then you have the teardrop cells, also known as the dacrocytes. Whenever you have a bone marrow fibrosis and these RBCs has to squeezed out of the bone marrow, right? They will form this teardrop type of cells. So they are seen in the myelofibrosis. Whenever you have a bone marrow infiltration and these RBCs will be squeezed out of the bone marrow, right? So this is about it. They are seen in the myelofibrosis. And in which cells are responsible for the myelofibrosis?
Platelets. Megakaryocytes.
Megakaryocytes, not the platelets. Okay. Then you have the cystocytes, which are the helmet cells. Also, you can call them. These are the fragmented RBCs. Okay. Whenever a thrombus formation occur, a minor thrombus, I must say, whenever a small thrombus formation occur and the RBC passes through that area, okay, they will be damaged. Okay, they will be fragmented, and now they are known as the cystocytes. So they are seen in the microangiopathic hemolytic anemia, like the DIC. Okay, the tissue thrombocytic purpura and the hemolytic uremic syndrome. Also, they are seen in the HELP syndrome, which is after the eclampsia. Okay, you can also see them in the mechanical hemolysis, like the heart valve prosthesis, in which you have a mechanical heart valve replacement, right? A prosthetic heart valve. Okay, so in any scenario in which you're having a microthrombi formation in the blood vessels, you can have the helmet cells or the cystocytes. Okay, and it happens whenever the RBCs passes through a thrombotic vessel, right? Examples include the DIC, the TTP-HUS, the HELP syndrome, and the mechanical hemolysis, which includes the heart valve prosthesis, which is the prosthetic heart valve implantation. Is that okay?
Yes.
And because the because the intravascular hemolysis is there, you can also have a high level of LDH and a low level of haptoglobin in that. Okay, other very important part to remember. And yeah, a bit. Then comes the demagacytes, demaxites, or the bite cells, very important. Okay, whenever you have a glucose 6-phosphate dehydrogenase deficiency, okay, in case of glucose 6-phosphate dehydrogenase deficiency, you have these Heinz bodies. And does anyone remember these Heinz bodies, what they're made up of?
Oxidized hemoglobin because of reactive oxidation.
Exactly. Yeah, this is the oxidized hemoglobin, and now this oxidized hemoglobin or the Heinz bodies will be removed by the spleen or the liver. And which cells in the spleen and liver will remove these Heinz bodies?
Macrophages.
Exactly, it is a function of macrophages. So the macrophages in the spleen and in the liver will remove these Heinz bodies, and it will form the DMAC cells, okay, and the bite cells. So it is seen in the glucose 6-phosphate dehydrogenase deficiency. Then comes the electrocytes. Okay, it is seen in the hereditary leptocytosis, okay, which is in the mutation, which is kind of a mutation in the genes which codes for the RBC membrane, of course. So you have this elliptocytes. Okay. Any doubt on this page?
No.
No, thank you.
Then comes the spherocytes. It is seen in two conditions. One is the hereditary spherocytosis, and second is the autoimmune hemolytic anemia. Very important. One is the hereditary spherocytosis, and second is the autoimmune hemolytic anemia. You will see the spherocytes. So how will you differentiate based on the PBS between the hereditary spherocytosis and the autoimmune hemolytic anemia? In both scenarios, you will have the
Test.
spherocytosis. Yes.
The Coombs test.
You can perform the Coombs test, no doubt, but based on the PBS only, by looking in the slide, how you can differentiate between the spherocytes and this autoimmune hemolytic anemia?
In hereditary spherocytosis, probably all the cells will be spherocytes, but in autoimmune hemolytic anemia, some will be normal.
Okay. Any other thing? It depends upon the probability, right? Sometimes it could be, sometimes it could not be.
Osmotic fragility test.
I'm seeing just based on the PBS, no other test, just by looking in the slides.
The size of the cell, like they are a bit larger in hereditary spherocytes.
No, size will be same. Both the spherocytes are of approximate same size. See, in case of hemolytic anemia, you are having the hemolysis, a large hemolysis of the RBCs. Now, what does the bone marrow do in response?
Reticulocytosis.
Yeah, it will do the reticulocytosis. It will release the immature RBCs, right? And sometimes this autoimmune hemolytic anemia becomes so much severe that even the nucleated RBCs can be seen in the PBS. Okay, so if you see the nucleated RBCs, many reticulocytes, and there's these cells, the spherocytes, that means you're looking for the autoimmune hemolytic anemia. when you see just the spirocytes and some reticulocytes, very mildly increased reticulocytosis will also be seen in this condition. So if you see just the reticulocytes and this spirocytes, that means you are looking for the hereditary spirocytosis. Is that okay?
Yeah.
So by just looking in the PBS, you can easily identify the case of the hereditary spirocytosis and the autoimmune hemolytic anemia. Now comes the macroevelocytes. These are the macrocytes which are seen only in case of megaloblastic anemia. Okay, and you always have the hypersegmented polymorphonuclear cells, or I can say the hypersegmented neutrophils also. So whenever you look in the PBS in which you are having this macroevelocytes, the oval-shaped cells, as well as the hypersegmented neutrophils, you will always think about the megaloblastic anemia. Okay. Then comes the target cells. Okay, and these target cells, they contain the central membrane in the RBC. See, in case of a normal RBC, you're having this biconvex shape, right? Yes.
Yeah.
In case of target cells, you're having this kind of shape in the RBC. Okay, these are the, and when you look from here, if you look from above, right, that you will see this kind of a structure, right?
Yeah.
These are target cells. They are seen in the HBC disease. They are seen in the sickle cell anemia also. They are seen in the asplenic patients, in the liver diseases, in the thalassemia. And does anyone know why the target cells are forming? What is the cause behind it?
Because of the increase in volume to surface area ratio.
Yes, whenever you have an increase in the volume to surface area ratio, you can have the target cells, right? Sorry, it is not the increase but decrease. You have more surface area in the volume, right? You have more surface area than the volume.
Yeah, right.
That's why the membrane, that's why this membrane is being accumulated there, right? Surface
Yeah.
area is more than the volume. Then only you can have the target cells. You know, that means you're having more membrane than the volume. Okay. And in see, in case of any liver disease and in case of asplenia, because you guys know that the macrophages are involved in case of this known as something splenic conditioning. Remember, you have the splenic conditioning in which the macrophages eat up the membrane of the RBC, right? So will decrease the surface area of the RBCs, and as a result, you will have this uh, biconcave cells, right? And same goes for the liver diseases, because the liver is also involved in the conditioning of the RBC. It will remove the membrane of the RBC and make them the biconvex shaped cells, right? So in case of liver diseases, in case of asplenia, you can have the target cells. In case of thalassemia, you're having a decreased volume of the RBC. Okay, in case of thalassemia, you're having a decreased volume of the RBC, and that's why you're having a more surface area to volume ratio, and that's why you're having a target cells in the thalassemia. Okay, in case of sickle cell anemia also, or in case of HBC disease, you're having a dehydration of the RBCs, and as a result, low volume of the RBCs, which means more surface area to volume ratio. Okay, and as a result, you can have the targeted cells in case of sickle cell anemia and the HBC disease also. Is that okay?
Yes.
Whenever the patient undergo the asplenia or the splenectomy, okay, initially you will see the targetoid cells in these patients, but later on, this function will be acquired by the liver. Okay, and when the function is acquired by the liver, you can no longer see the targeted cells in the PPS. Okay, so only in the initial time you will see the targetoid cells in case of asplenia. Is that okay also?
Yeah.
So don't forget that. Then comes the sickle shaped cells, and it is seen in the sickle cell anemia. We have discussed already why the sickling is occurring in case of sickle cell anemia. Okay, whenever you have a condition in which low oxygen is there or more CO2 is there, it will cause the sickling, just like the acidosis or the high altitude case. Any doubt on this page?
No, thank you.
Okay, so these are all about the RBC shapes. Okay, these are the shapes, different shapes of the RBC. Now, different aggregates or inclusions which are found in the RBCs. Okay, One is the iron granules, and these are seen in the sideroblastic anemia. Okay, it happens whenever the whenever the iron is there, but the heme formation is not occurring. Whenever the porphyrin pathway is inhibited, so that the porphyrins cannot be combined with the iron to form the heme. As a result, the whole iron will start accumulating inside the cells, okay, around the mitochondria, and it will appear as the ring sideroblast. As you can see, they have the ring-like structure. Okay, and these are the mitochondria around the nucleus. Okay, because the heme synthesis part is occurring in the mitochondria, so all of the iron will be start depositing in the mitochondria only, and the mitochondria will arrange themselves around the nucleus to form the ring-like structure, and that's why they call the ring sideroblast. Okay, so whenever you do the this staining, the Persian blue staining, you can visualize the this iron as the bluish appearance. Okay, very important. And where does you find these cells, the ring sideroblasts? Where does these cell found? In the bone marrow or in the PBS?
Marrow.
Yeah, in the bone marrow only you can see the ring sideroblast, because the RBC formation is taking place in the bone marrow, right? And because at the time of RBC formation you also require the heme, so that means the heme formation also will be taking place in the RBC. Sorry, will also be taking place in the bone marrow, right? So all these sideroblasts, they only can found in the bone marrow, not in the peripheral blood smear. So what you will find in the peripheral blood smear in the patient with this sideroblastic anemia? The microcytes only. Okay. Yes. The microcytes.
Microcytes.
Yes.
Okay. Yeah.
Okay. So whenever the step one asks you about this also, please make sure if they're asking about the bone marrow or they're asking about the PBS. If they're asking about the bone marrow, then only you will choose the ring sideroblast in the option. Otherwise not. Okay. And this is for the axis of iron deposition, right? Then you have the peripheral blood smear, in which you can see the Howell Jolly bodies. Okay. And these are the nuclear remnants of the RBCs. Okay, and they're made up of DNA part. Please remember, the Howell Jolly bodies are made up of DNA, right? And they're seen in the functional hyposplenia, like in case of sickle cell anemia or the orthosplenectomy. In case of any asplenic patient or in the sickle cell anemia, you can have the Howell Jolly bodies. They are normally removed by the splenic macrophages, but the splenic macrophages are not there. That means you can have the Howell Jolly bodies. Okay, and this is the basophilic stippling, and please note this figure is not for the basophilic stippling. This figure is actually the mast cell or the basophil cell. Okay, so you can just cross it out in the FA 2020. I think FA 21 has updated it, right? Please respond. FA 21, does it updated or not?
Yeah, it's updated.
So you can remove the this diagram from the FA 2020. This is for the mast cells, not for the basophilic stippling. Okay. So you see the basophilic stippling in case of sideroblastic anemia and also in case of thalassemia. Okay, and they are the basophilic ribosomal precipitates. Okay, these are the precipitates of the ribosome second. So whenever in the step one, you are seeing the basophilic structure anywhere inside the cell, in case of neutrophil or in the reticulocytes or in the RBCs, most of the time they're gonna be the ribosomes only, the RNA in the ribosomes. Like the Dole bodies, which are basophilic, these are the RNA, the ribosomal RNA. In case of reticulocytes, they are kind of bluish. Why? Because of the ribosomal RNA. Okay, in case of basophilic stippling, they are basophilic because of ribosomal RNA, right? So most of the time it is gonna be ribosomal RNA. You just need to remember few exceptions, like in case of Howell Jolly bodies, it is a DNA. In case of Pappenheimer bodies, okay, these are the iron bodies you will see in the sideroblastic anemia, because in case of sideroblastic anemia, you're having a very high iron inside the cell, right? So the Pappenheimer bodies are also the iron bodies. These ring sideroblasts are also the iron bodies, and these Pappenheimer bodies are seen in the peripheral blood smear along with the macrocytosis, right? Then the Heinz bodies, okay, and you already know about that. These are the oxidized hemoglobin. Okay, so only few exceptions: the Heinz bodies, Pappenheimer bodies, and the Howell Jolly bodies. These are containing the iron. Sorry, the oxidized hemoglobin, the iron, and the DNA. Rest all, whenever you hear about the basophilic thing in the RBCs or any other cell, that means they're talking about the ribosomal RNA. Is that okay?
Yes.
And how does you see the Heinz bodies? It is by the crystal violet staining. Okay. That would be it. Any doubt on this page?
No, thank you.
Okay, now let's discuss the anemias. Okay, you have divided the anemia into three parts, three types. One is the microcytic type, second is the normocytic, and third is the macrocytic. For the microcytic type, the MCV is less than 80 femtoliter. For the normocytic type, the MCV is between the 80 to 100. In case of macrocytic type, the MCV is more than 100. Okay. The causes of the macrocytic anemia, it includes some, any disorder which involves the damage of the hemoglobin, either the heme part or the globin part, right? For the heme part, it requires the porphyrin and the iron, right? So it could be the anemia of chronic disease. It could be the iron deficiency anemia. It could be the lead poisoning. It could be the sideroblastic anemia. In all these disorders, you're damaging the heme part, right? Like in case of anemia of chronic disease, you're not having iron. If the iron is not there, then the heme cannot be synthesized. Similarly, in case of iron deficiency anemia, you're having a deficiency of iron. Okay, the heme cannot be synthesized. In case of lead poisoning and acidoblastic anemia, you will be having a deficiency of porphyrin, right? So the heme cannot be synthesized. Then the globin chain, which is a defective in the, which become defective in the thalassemias, right? So the heme defect or the globin defect can lead to the microcytic type anemia. Is that okay?
Yes.
Then comes a normocytic type, in which it is of two types, the non-hemolytic and the hemolytic. In non-hemolytic type, you will have a low reticulocyte index. In the hemolytic type, this bone marrow will respond and it will increase the reticulocytes, right? So you will have a high reticulocyte index in case of hemolytic type and a normal or a low reticulocyte index in case of non-hemolytic type. It includes the iron deficiency anemia. At a very early stage of the iron deficiency anemia, you will be having a normocyte in the blood. In case of anemia of chronic disease, mostly whenever you encounter a case of anemia of chronic disease in step 1, it is always going to be a case of normocytic type. Okay, in a very later stage of this anemia of chronic disease, you can have the microcytic type of anemia. Then the aplastic anemia also, and the chronic kidney disease, you will have the normocytic type anemia. Okay. Then comes the hemolytic type anemia. Okay. And the hemolysis could be of two things. It is either could be due to the intrinsic disorder or it could be due to the extrinsic disorder. Okay. The causes of intrinsic disorder includes any membrane defect, like in case of hydatid spherocytosis. Okay. Like in case of paroxysmal nocturnal hemoglobinuria, in which this the anchoring protein is lost from the membrane, and now the complements can active against the RBCs, can destroy them, right? So the hemolysis is happening and because of the membrane defect. Second is the enzyme deficiency, like the glucose 6-phosphate dehydrogenase deficiency or the pyruvate kinase deficiency. In both of these scenarios, you can have the hemolysis because of the enzyme loss. Third is the hemoglobinopathies like the sickle cell anemia or the HBC disease. Okay. Then the extrinsic causes of hemolysis. First is the autoimmune hemolytic anemia. Okay. Second is the microangiopathic hemolytic anemia. Third is the macroangiopathic hemolytic anemia. And fourth is the infection. Infection like plasmodium, okay, malaria. They can cause the hemolysis. They can cause the extrinsic hemolysis, right? So any doubt on this part?
No.
Okay. Third one is the macrocytic type, in which you have the MCV more than 100 femtoliter. Okay, you will call them the megaloblastic anemia or the non-megaloblastic type anemia. In case of megaloblastic anemia, the DNA is affected. Okay, and it is could be due to the deficiency of folate, could be due to deficiency of vitamin B12, or due to the uric acid urea. Does anyone remember what enzyme is deficient in uric acid urea?
UMP synthase.
UMP synthase, yes. And second is a defective DNA reparation, which is the Fanconi anemia. Remember what kind of DNA repair is kind of defective in case of Fanconi's anemia?
Homologous end joining.
Yes, homologous end joining. Very important. Okay, now second one is the non-megaloblastic type, which you have the Diamond-Blackfan syndrome or a Diamond-Blackfan anemia. Any kind of liver disease can cause a non-megaloblastic type of anemia. Alcoholism can cause the non-megaloblastic type anemia, and in the later stages, when they become deficient of vitamin B12 and the vitamin B9, they can also cause the megaloblastic type of anemia. Any doubt?
No.
Oh, thank you.
Now you remember the rule of three. Okay, see, you have the RBCs which are around 5 million, right? If you multiply this 5 million by 3, you can have the hemoglobin of 15, right? If you multiply the hemoglobin with 3, you can have a hematocrit of 45%. Okay, so first is the RBCs. RBCs multiplied by 3 will gives you the hemoglobin value. Hemoglobin multiplied by 3 will gives you the hematocrit value. For example, if you have a RBCs of 5 million, you can have a hemoglobin of 15 gram per deciliter, and you can have a hematocrit of 45%. Is that okay?
Yes.
Now you have the reticulocyte index, okay, which will show whether the appropriate, compensation by the bone marrow is taking place or not. If you have a high reticulocyte index, that means the appropriate compensation is happening. The immature reticulocytes are being released in the blood. If the reticulocyte index is low, that means the bone marrow is not responding to the hemolysis, which means the hemolysis or the anemia is happening because of any defect in the bone marrow itself. Okay. And the reticulocyte index will be equals to reticulocyte percentage multiplied by the actual hemoglobin divided by the normal hemoglobin. Okay, very important. Note that well. So yeah, that would be all about reticulocyte index. Any doubt?
No, thank you.
Now let's discuss the causes of the microcytic hyperchromic anemias. Okay, the first one is the iron deficiency, and yeah, we have discussed that already. That in case of microcytic anemias, you will be having a low level of hemoglobin, right? Along with the microcytes, you will be having a low level of hemoglobin, and that's why they are known as the hyperchromic. Okay, so microcytic hyperchromic anemias. The MCV or the volume of RBCs is less than 80 femtoliter in all these scenarios, right? And the first one is the iron deficiency. How you can have a iron deficiency? It is by the decreased absorption of the iron, okay, or by the increased loss of iron. Okay, like in case of in case of loss of iron, you will have a very chronic bleeding, like in case of any GI bleeding, and we have discussed the causes of the GI bleeding, right? In case of old age, it could be the colon cancer, right? In case of any diarrhea, any kind of bloody diarrhea can cause that, right? And yeah, second thing is the menorrhagia. In the women of the reproductive age, they have these menstrual cycles, right? And they have a regular bleeding also, right? And this will cause the iron deficiency. Very important. This is the most common cause of iron deficiency anemia in the woman. Whenever you encounter a woman of age between 13 to 50 years, okay, and they're having the iron deficiency, the most common thing you will always think about is the iron deficiency. Very important. Okay, whenever in the exam you encounter a female with age between 13 to 50 and they're having this anemia thing, step one can ask you what would be the most probable cause of the anemia. It would be the iron deficiency anemia. Okay, second thing is the malabsorption, okay, in which you have a decreased absorption of the iron also. Third thing is that absorption disorders, like in case of celiac disease, you can have the iron absorption disorder. In case of bacterial overgrowth syndrome, you can have iron loss also. In case of any gastrectomy, you can have the iron loss, right? In case of pregnancy, you have an increased demand of the iron, right? In that case also, you can have the iron deficiency anemia, right? And so any disorder which includes the duodenum, which will involve the duodenum, you can have the decreased iron absorption, right? The proton pump inhibitors, you guys know that acidic medium is required for the absorption of iron. If you use the proton pump inhibitors, you will have a decreased acid production, you will have a decreased iron absorption. Okay. And yeah, then you have some parasites also. Remember the blood sucking parasites, the name of them?
Hookworm.
What worm?
Hookworm.
Nectar american and Ankylostomum duodenalis.
Yeah, exactly. And celostoma and the negator, right? They will suck your blood and they will cause the iron deficiency anemia also, right? So causes includes the first is that increase in the blood loss. Okay, any kind of trauma can cause it. The postpartum hemorrhage, if you guys remember, it can also cause the iron deficiency anemia, right? Any GI loss, menstrual cycles, the most common in the female, right? Malnutrition or the absorption disorders, right? Or the parasite causes, right? They all can cause the iron deficiency anemia. What are the labs? You will have a low level of iron. You will have a high TIBC. Because of low ferritin, whenever you have a low ferritin, you will always have the high TIBC. The affinity of the transferrin for the iron is increased, right? So whenever you have a low ferritin, you will always have the high TIBC. Okay, you will have the low overall iron in the body and the free iron levels also. Okay, you will also have the increase in erythrocyte protoporphyrin, because you know that the protoporphyrin must be combined with the iron to form the heme. But now the protoporphyrin will be forming, but the iron is not there. Okay, heme is not there, and as a result, the patient will also have an increased free erythrocyte protoporphyrin. You will also have the red cell distribution width, in which you have a different sizes of the RBCs. Okay, you will also have a decrease in the reticulocyte index because the iron is not there. That means the bone marrow cannot form the RBCs, right? When the bone marrow cannot form the RBCs, you will have a low reticulocyte index because the disorder ultimately affecting the bone marrow, right? Not the peripheral blood only. Is that okay?
Yeah, yeah.
On the PBS, you will see the microcytosis and the hypochromasia. Okay, in case of hypochromasia, you will have a very large central pallor. Okay, they haven't shown it here, I think. Yes. Yeah. This is the hypochromia, you can see, right? The central pallor of the RBCs is increased. Okay, this is how you see the microcytic hypochromic anemia in the PBS. So what are symptoms? Symptoms, because the RBCs are not there, oxygen delivery to tissues will be reduced, and as a result, what you can have is the fatigue because of low oxygen, because of low hemoglobin, low RBCs. You can have the conjunctival pallor also. Okay, you will have the pica, in which you have a constant, a continuous cravings of eating the non-food substances like the ice, okay, like the chalk, or like the dust, or something like that. Okay, so pica is there. Spooning of nails is there, which is known as a koilonychia, right? Your lips will become dry. You will have the burning pain in the mouth also. Okay, you will also have the glossitis. You will have the chelosis. Okay, and sometimes you can also have the Plummer-Vinson syndrome. If you guys remember, you have the esophageal valves in it, and this iron deficiency anemia and the dysphagia, right? And specifically in case of Plummer-Vinson syndrome, you will also have the beefy red tongue. So whenever you encounter a patient having a beefy red tongue along with the dysphagia, okay, and some fatigue, that means the patient is having a Plummer-Vinson syndrome and the patient is having a iron deficiency anemia. Is that okay?
Yeah, yeah.
These are all the causes. These are all the symptoms for the iron deficiency anemia. And in doubt?
No, thank you.
Okay, then comes the alpha thalassemia, in which you have a defect in the alpha globin gene. Okay, and because the defect is in the alpha chain, now this disorder can also causes of problems in the fetus, right? So in this case, you will be having a decreased alpha globin synthesis. Okay, because of the mutation, because of the deletion of the genes. Okay, you will be having a decreased synthesis of the alpha globin chain. You have total of 4 genes for the alpha chain formation. Okay, very important. And this thalassemia is because of the deletion in the alpha globin gene, so that the alpha chains formation will be reduced. Okay, you have 2 type of deletion. Either it could be a cis deletion or it could be a trans deletion. In case of cis deletion, the deletion occur on the same chromosome. Okay, in case of trans deletion, the deletion will be occurring on a different chromosomes, on separate chromosomes, right? And you will represent the cis deletion as the alpha alpha, which is the same chromosome, and the dash dash, which means the deleted alpha genes on the same chromosome. In case of translation, you will represent it like this: alpha dash and the alpha dash, which means the alpha genes are lost on the different chromosomes. Okay, and yeah, The cis deletion mainly seen in the Asian population, and it is kind of more severe than the trans deletion, which is seen in the African population. Okay, and the normal one will be represented as alpha alpha and alpha alpha. Is that okay up to here?
Yeah.
Okay, so first scenario in which you have a one deletion of the alpha gene. Okay, as a result, because the three chains are still normal, they will form the this alpha gene, this alpha chain very normally. So you do not have any kind of anemia. They are just a silent carrier of the disease. Okay. Second thing, you will have two deletion in the genes. Okay. In second thing, you will have a two deletions. Okay, either it could be a trans deletion or it could be a cis deletion, right? In this thing, because you're having a loss of two chains, loss of two genes, right? So you can have a mild microcytic and hypochromic anemia on the PBS, right? And and like we have discussed, the cis deletion will have more impact or a more severe outcome than the trans defect. Okay, because a trans will be having a loss from different chromosomes, but the cis will be having a loss of genes from the same chromosome, right? And it depends how much these alpha genes are lost. Okay, if the one alpha gene is lost, that means that 25% of alpha gene is lost. If two alpha genes are lost, that means that means a 50% of the alpha chain is lost. Okay, if three alpha gene is lost, that means 75% of this chain is lost. If all four alpha is lost, that means the 100% is lost. Is that okay?
Yeah.
So what does step one can do on these questions? They will give you the history of the parents. Either they could be a carrier, okay, or they could be of or they could be having the alpha thalassemia minor, either a cis type or a trans type. They will mention you this, and then they will ask you what could be the fetus having. Okay, how much percentage of the alpha chain the fetus could be having, right? So they can ask you something questions like that. Okay.
Yeah.
So just give me a second. So let us suppose if you encounter a parents, okay, and both of the parents are having a trans type of alpha thalassemia minor, okay, then what can they do? They can either transmit, uh, well, they can either transfer this chromosome alpha dash, or they can transfer this chromosome the alpha dash. Okay, so in all of the cases, okay, if I draw the Punnett square, then the alpha dash, and alpha dash and alpha dash, right? In all of the cases, the baby must be having the alpha dash and alpha dash, right?
Yeah.
Consider this as a one chromosome and this as a second chromosome, right? And the parents can transfer either this chromosome to the fetus or this chromosome to the fetus. If both the parents would transfer this one, then then doesn't matter what the case is, the fetus will always have the alpha dash, right? And so how much working alpha gene, this alpha gene will this offspring have?
50%.
50% only, right? It will be carrying only the 50% of the oxygen. Now, if we have a cis type of alpha thalassemia minor, okay, then the parents can either transfer the alpha alpha normal, okay, or they can transfer this no alpha at all. So if I want to draw the case, this is my Punnett square. Okay, this is for the alpha and alpha normal. Okay, this is for the no gene at all. Similarly, the alpha alpha here, okay, or rather no gene at all. So the offspring can have a normal type of hemoglobin which contains of alpha alpha and alpha alpha, okay, a normal genes. It can either have this alpha alpha slash no gene at all. It can either have again the alpha alpha and the no gene at all, right? And again the absent cases, right? So 50% of chances of being a cis carrier, okay, having alpha thalassemia minor with cis type, okay, 25% chances of having a normal baby, okay, which contains all 4 alpha genes, and 25% chances of not carrying any of the alpha chain or alpha gene. Is that okay?
Yes.
So if the fetus it do not contain any of the alpha chain, any of the alpha gene, what can happen to the fetus now?
No hemoglobin in the fetus.
And this is known as the hemoglobin Bart's disease. It will lead to the hydrops fetalis because no oxygen will be there for the tissues. Hypoxia will happen. Okay, high output cardiac failure will happen, and that can lead to the fetal hydrops. And that's why the FA mentioned this point that the cis deletion may have a worsened outcomes for the carrier offspring. Is that okay? Because they
Yeah.
have a 25% chances of not carrying any of the gene at all. Okay, and as a result, the patient can, the fetus can die in the womb only, in the fetal life only, right? Very important to note. So they can either ask you about the transmission of these genes, about the transfer of these genes, how the hereditary transmission of the genes occur. They can ask you about the symptoms of the patient in case of alpha thalassemia minima. Only you have the 75% of genes working, 75% of chain is there, so no symptoms at all. In case of minor, 50% of symptoms will be there. You will have a mild microcytic anemia, hypochromatic anemia, right? They will ask you about the cisletion or translation. Okay, what will be the outcomes to the patient? Okay. In the third scenario, you are having a 75% deletion of the alpha chains, of the alpha genes, and now you have only 25% working alpha chain. Okay. It can lead to the moderate to the severe microcytic hypochromatic type anemia. Okay. It is known as the HBH disease because now you have more free beta chains, right? And these beta chains will combine to each other. Instead of alpha 2 and beta 2, now you have the beta 4 because of free beta chains, right? And this is known as the HBH disease. Is that okay?
Yes.
And this beta tetramers, when they form, the beta 4, the beta tetramers, when they form, okay, they become very, they cannot bind to the 2,3-BPG no more. And as a result, they will have an extremely high affinity for the oxygen. Okay, they will have this extremely high affinity for the oxygen. They cannot release the oxygen to the tissues. And as a result, the hypoxia to the tissues will occur that can lead to the that can lead to the erythrocytosis. Okay, very importantly, you will have a high hematocrit value. HCT will be very much high. Okay, and but ultimately you're having the anemia because of loss of oxygen, right? And yeah, that would be all about this tetramer. And can anyone tell me how this tetramer units, what kind of hemoglobin they mimic?
Myoglobin.
Exactly, myoglobin, which has the highest affinity for the oxygen. They will mimic like the myoglobin. Very important. Step 1 can ask you this fact also. In the fourth scenario, you're having a deletion of every gene of this alpha gene, right? So in that case, you are not having any alpha chain. Okay, and by birth, okay, even in the fetal life, okay, this disease will present itself. Okay, and it is known as the hemoglobin Bart's disease, in which the gamma genes, the gamma chains which are present, they will combine with each other to form the gamma tetramers, and that can lead to the fetal hydrops. Okay, and it is completely incompatible with the life. The fetus will die uh, early in the pregnancy only, right? Is that okay?
Yeah. Thank you.
So this is all about the alpha thalassemia. Any doubt?
Will gamma 4 and beta 4 both behave as myoglobin?
Yeah, both can behave as a bioglobin.
Okay, got it. Thank you.
Now comes the beta thalassemia. See, in case of alpha thalassemia, you were having a deletion, right? In case of beta thalassemia, you are having a mutation. And as we have already discussed, this beta thalassemia is an example of what kind of what I can say. Remember the genetic terms? We have discussed a certain terms.
Splice site mutation.
Yeah, it has multiple type of mutations on the same gene, and all of the mutations are forming
Allelic
the same gene.
heterogeneity.
Exactly. It is an example of allelic heterogeneity. Okay, very important. So in case of beta thalassemia, you can either have the splice site mutation or the promoter sequence defect. Okay, or it could be a defect in the Kozak sequence. Remember the Kozak sequence for the translocation, for translation, right? So any kind of defect can happen in the, any kind of defect can happen in the beta thalassemia, and all of the defects are on the chromosome number 11 for the beta thalassemia genes. So you have two type of beta thalassemia. One is the beta thalassemia minor, and second is the beta thalassemia major. In case of minor, you have the beta chain which is underproduced, decreased formation of the beta chain, and as a result, you will have a low level of hemoglobin A1, HbA1, and an increased level of HbA2 because the HbA2 contains alpha 2 and delta 2, right? So this would be normal, and it is slightly increased also. So a decreased level of HbA1, increased level of HbA2, okay, that you will see in the beta thalassemia minor. Okay. In case of beta thalassemia major, you're having the mutation in both the genes for the beta thalassemia. Sorry, for the beta chain. And as a result, the beta chain is now absent from the blood. As a result, you will be having a severe microcytic hypochromic anemia. Okay, the target cells will be seen. And isopoikilocytosis will be happen, which means that varying size of RBCs and a varying shape of the RBCs are present. Some are sickle shape, some are targetoid cells, some are spherocytes also, some are nucleated cells. Okay, multiple type of RBCs are seen in the PBS, right? And these patients will require the blood transformation because they cannot synthesize the normal alpha chain, they cannot synthesize the normal RBCs, so they require the external RBCs, right? So they require the blood transfusion. And with the chronic blood transfusions, these patients can also have the secondary hemochromatosis, right? Their bone marrow will try to compensate, okay, and they will expand, the bone marrow will expand, and they will give the skull a crew-cut appearance, okay? Skeletal, the deformities will be there, like the chipmunk faces, okay, and a crew-cut appearance. And now because the, because your bone marrow is now not much sufficient to overcome these things, right? The bone marrow has not the capability to overcome this kind of anemia. So what's gonna happen? The extramedullary hematopoiesis will also start. Okay, EPO will be released, and this EPO will stimulate the extramedullary hematopoiesis, like in the liver, in the spleen. So in that case, you can also have the splenomegaly and the hepatomegaly. And when you do the biopsy of the spleen and the liver to check why the hepatomegaly is occurring and the splenomegaly is occurring, what you will see is the hematopoietic stem cells island. Okay, so step 1 will ask you why the hepatomegaly and the splenomegaly is occurring in the patient. It is because of the RBC precursors in the spleen and liver. Is that okay?
Yes.
And because these cells are forming and destroying, right? These cells are keep on forming and keep on destroying. The RBC lifespan in these disorders are very much reduced. And above that, if you have an infection of the parvovirus P19, which will affect the what cells?
Erythroblasts.
Yeah, normoblasts or erythroblasts, right? In that case, okay, your RBC production is now halted. Whenever the parvovirus P19 infection occurs, the RBC's production is now halted. You already have the anemia. Above that, you have the parvovirus P19 infection will further reduce the RBC production. As a result, you will have the aplastic crisis with this infection. Is that okay?
Yeah.
And what is the lab things you will see? You will have the high level of fetal hemoglobin. You will have an absent HbA1. Very important. In the beta thalassemia minor, you will have still some values of the HbA1 as well as increased value of HbA2. In case of beta thalassemia major, you do not have any HbA1. You have just the HbF and the HbA. Okay, and the HbF is kind of protective for the infant. Okay, because it contains the normal chains, the alpha 2 and the gamma 2. Okay, so you have to maintain the level of HbF in the patient, to get a symptomatic relief from the beta thalassemia, right? And how you can do so? You can give the patient what drug to maintain the HbF level?
Hydroxyurea.
Hydroxyurea. But again, a side effect is associated with the hydroxyurea, and that is a megaloblastic anemia, right?
Yeah.
and the disease will become symptomatic only after the 6 months, because up to the 6 months, the level of fetal hemoglobin is kind of very much high. Only after 6 months, the beta chain will start replacing the alpha chain, right? And at that time, the symptoms will start occurring, right? So, any doubts so far on the beta thalassemia and alpha thalassemia?
Could you please repeat the last sentence regarding the 6-month duration?
See, up to the 6 months, you are having this fetal hemoglobin levels very high, the gamma chain, right? Only
Yes.
after 6 months, the beta chain will start replacing the gamma chain. And at that time, after 6 months, the symptoms of the beta thalassemia, the fatigue, the paleness, the jaundice, the microcytic hypochromatic anemia, right? All of these symptoms will only arrive after the 6 months. Before
Okay.
6 months, the patient will be absolutely normal. But in case of alpha thalassemia, it will be evident soon as birth or even in the fetal life also.
Yeah. Okay. Thank you.
There's a huge difference between the alpha thalassemia and the beta thalassemia, right?
Yes.
And any more doubts so far? No?
No, thank you.
Okay, guys, can we take the 2 days off at here? Actually, I have to go somewhere today. That's possible.
Yeah, of course.
Thank you.
Thank you so much, everyone.
Thank you so much.
Yes, so much.
I'm sorry about that. We have to take off early.
It's absolutely fine. Thank you.
Thank you so much.